Okay, so we are live now. Okay. Just let me check few things before I start. So we'll start the session in 2-3 minutes and welcome to all those who have joined. Dr. Tarek, welcome from Bangladesh. I started 2-3 minutes so that we can check everything is working fine. I hope you all were able to hear me and my voice is clear. Dr. Faizer, good morning. Dr. Adil, once someone is medico. So 2 minutes left and then we'll start the session. Dr. Rani from Port Blair, wow. Dr. Mukund from Rishikesh, wonderful. Ames, very nice. Thank you all for joining. Just one more left and then we'll officially start the session. Tanzania, Dr. Sibten, sorry if I didn't pronounce. Dr. Munib, oh, Dr. Goel from USA. Good morning. I think there must be night, I think, and thanks for joining from there. Just one more left. Dr. Sarang, thank you for coming again. Dr. Chirag mentioned your name yesterday. So one more minute left and then we'll start. Okay. Can you people tell me that whether my voice is coming clearly to you or audible to you in the chat box? Okay. So it's 10 a.m. and in Indian Standard Time. And good morning to all. Welcome to all. Namaste to all. Those who are listening this session from various part across the world. So before starting today's session, the topic of today's session, as you must have known in the seen in the thumbnail. Thank you, Dr. Feza, for identifying that voice is coming. Thank you. Good morning, Ramya. Dr. Ajay from Chennai. So okay. So today's session is mechanical ventilation concepts, graphs, and troubleshooting. So you understand that today's session will be in three parts. One will be we'll understand the concepts of the ventilator. Then in the second part later on, we'll go in understanding the graphs which comes on the ventilator. And third part, once we have understand the concepts, then we understand the graphs. In the third session, we'll be understanding the how to troubleshoot, how to identify the various troubleshooting on the ventilator. So now I thought of making this lecture. I gave a lot of thought that how we should discuss this on the live stream, how we should prepare the lecture, how I should prepare. So one thing came in mind, like a routine PPT in which there are the slides coming and then we are interacting on the slides, and so I thought this will not be an interactive session, this will be a monotonous one. So we tried something new. It's how we teach, how we discuss among our teammates in the ICU, with my colleagues in the ICU or my students in the ICU. We try to create that environment so that we can understand in a better way. So what will we have? We have 4-5 screens which I have tried to set up. One which you are seeing me in the camera right now. In this, whenever there is certain concept which I need to explain in detail, will be interacting to this phase. Now the second will be this, my iPad screen or a PowerPoint sort of screen where I will show you the concepts. Third will be your comments, which will take in the routine section, routine discussion, your comments which will take. And the fourth will be certain facts, certain graphs on the Google. Means all of us use the, I think my voice is hampering. Let me, hello, I think it's clear now. It's not disturbing you all. Okay. So what we'll do in the third part, what we'll do in the fourth screen, there will be Google Chrome. I want to make you understand that whatever we are discussing, it's not very difficult. Everybody can do this. Everybody can think of it, and whenever they want something, they can Google it and find the reliable resources, then can interpret them. So let's start. One important thing, whenever you have any questions regarding anything which I am discussing, you can post it in the chat box and I'll try to take all the questions in the session. The pace of the session will be neither very slow, neither very fast. It will be in a smooth pattern, so that everybody who is even new to the ventilator, there are many audience which will have not used ventilator for past, and there are many who are experts of this ventilator in their routine ICU or ER. So what we'll do is we'll keep the pace something like that, in which everybody who is very much even if not comfortable with the ventilator, or those who are very well versed with the ventilator, everybody get to know something about it. For everyone the concept is clear and nobody gets bored. How much time this session will take, I really don't know, but the point is I want to make everything clear. Almost 95% of the things we'll cover in today's session. So once you have discussed everything in today's session, you will be very confident when you go into your ICU. Now one more important thing to all those who have joined, this is a basic version, a little more than basic and moderate what sort of session is today's session. We'll be planning an advanced version of this, in which I will connect you with not only with YouTube live stream, also with the Zoom, in which the selected audience, some 60, 70 or 80 people, I will allow them to join through the Zoom and interact with me, so that we can discuss the advanced concepts of the ventilator, with the remaining 5-10% which will not cover today. But for your daily practice, for those who are working in the ICU in a routine manner, today's session will cover almost all the things which is required to work in the ICU. Then for the advanced version, we'll take on later on. So I have prepared my notes for today, so that I didn't forget anything which I need to tell you. I don't miss anything which I need to tell you. So let's start. So what is a ventilator per se? What is a ventilator per se? So before understanding ventilator, you need to understand that there are two things. One, a breath which you are taking, which a patient is taking normally, and the second one is the ventilator which is providing the artificial breath to the patient. Even if I am not acknowledging those who are joining, make sure there is screen in front of me. I am able to see everyone who is joining, like Dr. Arthur from Oman. So every comment is in front of my screen, so I am keeping a watch on it. So whatever you feel in your mind, if you what you want to ask in the lecture, just post so that we can go through and discuss all those questions. Now, can we start now? If everybody is comfortable, have some water with you. Uh, be comfortable. This is not going to be a very formal one. It's a casual one, but we'll cover everything. So can we start? Let me know in the chat box, because I'm not very well versed with the live stream, but I tried. So can we start the session? Okay. Okay. I think there is a 1 or 2 minute, 30, 40 seconds delay in what my voice is coming and when it is reaching you. Okay. So with this 6 or 7 minutes of introduction of today's session, let's start. So whenever you let me keep my phone silent. Yes. Okay. So when you think of ventilation, you need to think that what do you mean by ventilator? Ventilator is something which provides artificial breath to the patient. So you need to understand the difference between your normal breath which a patient takes and an artificial breath which a patient which you provide to the patient. Also, the difference between oxygenation and ventilation. When you provide oxygenation to the patient, it can be through your oxygen mask or BiPAP machine, but not by BiPAP machine, but because it's an IV. But in ventilation, you are basically expanding and collapsing the lungs, and you are taking care of the PCO2 also. That's why it is termed as uh, ventilation. So in a normal breath, what happens? You inspire the air, then there is a lung and there is a dip in the intrathoracic pressure. Your lung expand, the vacuum is created, and there is a dip in the intrathoracic pressure, and then the air flows in. And when you exhale, what happens? It's a passive process. The intrathoracic pressure rises and air comes out of your breath. While 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 in a ventilative breath, what happens? You provide positive pressure. You blow the air into the lungs. So in inspiration, there is a positive pressure inside the lung, and then during inspiration there is a positive pressure, and again on ventilator also it's a passive process, so that your ventilator becomes silent and the lung exhales the air or through the ventilator tubings. So first, this is very important concept. Let me show you how. See, just hold on. You see here, in spontaneous ventilation, this is spontaneous ventilation. Oh, like this is spontaneous ventilation. In this inspiratory muscle, you are able to see here my screen. I think yes, screen is visible. So what happens? Your inspiratory muscle collapse, because this is the difference between your spontaneous mode ventilation and positive pressure ventilation. Now intrathoracic volume rises, your chest expands. There is a fall in the intrathoracic pressure. The pressure, the vacuum is created, pleural pressure decreases. We'll come to that. Transpulmonary pressure will come to that. Important is lung volume expands. Alveolar pressure decreases. Means when the alveoli opens up, this is the airway, this is the parenchyma, and when the alveoli opens, then the alveolar pressure decreases, and then air flows into the lungs and equalizes to the atmospheric pressure. This is how spontaneous ventilation works. But during a positive pressure ventilation, why it is called positive pressure ventilation? Because you are blowing the air into the into the patient. So ventilator increases the proximal, it blows the air into the patient's lung. Air flows into the lungs, alveolar pressure rises, it's not decreases. Your alveoli expands, and there is an increase in the transpulmonary pressure, and the lung volume expands. So this is the basic difference between a spontaneous breath and a ventilative breath. There is one very good diagram there is a very one good diagram. Let me explain you by that. Just give me 1 minute so that uh, I can show you that thing which I am trying to show you. Just hold on. Sorry, because I have not prepared PPT because I want to be interactive so that whatever is required, I should tell you. Mm, just hold on. There is a very beautiful diagram inside and here. Okay. Okay. 1 second. Okay. So I think now it will be visible on my screen. This is a very beautiful diagram. Okay. So what this diagram is showing, that you need to understand three four pressures. One is your from mouth to your airway. This is tracheal airway, the airway. And then when the lung it divides into right or left bronchus, then you have different sorts of alveoli, and this is parenchyma. So, and there is a pleura outside the lung parenchyma. So basically you need to understand the three things. One, there is an airway which is from trachea to the bronchus and different terminal bronchiole. So this is one part, which is the airway tubes which are conducting the air. Second is your alveoli, which are air pockets, which is parenchyma, and outside those lung is your pulmonary pressure, pleural pressure. So the normal tendency of the lung is to collapse. Your pleural intrathoracic means the rib cage keeps the lungs expanding. So the pressure inside the airway is equal to the alveolar pressure. The inside the pressure which is inside the alveoli is known as alveolar pressure, and the difference between the alveolar pressure and the pleural pressure, means between the two pleura, is called transpulmonary pressure. These two differences you need to understand, because the normal tendency of the lung is to collapse, while the rib cage keeps it expanding, and the balance between two keeps the lungs open. So we'll come to these points later on this session. This is what it's explaining. This is your alveolar pressure and this is your pleural pressure. So whenever your lung you blow air into the this parenchyma, they expands, while in spontaneous respiration the transpulmonary pressure decreases and your lung expand. So don't get confused about this. Let's see different parts of the ventilator. So first we'll discuss different parts of the ventilator. Let's uh, okay. Just a second. Okay. Now you can see in this graph, this is a typical ventilator. Many of you are very familiar with this ventilator, but still I would like to. Good morning, Dr. Shilpa. Very nice to see you. Desai madam. Namaste, and thank you for joining the session. I'm very thankful to you. You have joined the session. Okay. So this is your ventilator. You can see there are two ports coming. One is your oxygenation port and one is your air pressure port. Because in your from ventilator you can give 21% FiO2, which is your which you are on the room air, and you can give 100% of the FiO2. So there is a blend of oxygen and normal air. So these two ports are there. One is oxidation and the other one is of air pressure. Now this is your ventilator screen. This part, this part, sorry, this is the part of the ventilator screen on which you set the parameters which you want the patient to, which you set on the ventilator and which are given to the patient. We'll discuss all these parameters. So this is the part of the screen by which you set the amount of breath to the patient. Now this is the topmost part, the second part, the above part. This is the part of the ventilator which shows you what is happening with the patient. You have said something on the ventilator, but what is happening to the patient on the ventilator? How the breath is getting generated? What are the graphs? Suppose you have used a tidal volume of 500. How much tidal volume is getting generated into the patient? So this is thing. Now you have certain buttons here for alarms, resetting alarms. You can also see this is your two ports. One is inspiratory limb, the breath which you are providing to the ventilator, and the other one is expiratory limb, which you are which from which the breath is coming back to the ventilator. Like I show you in like this. Uh, okay. Okay, so you see here, now this is typical ventilator. One, this is breath. You have two ports behind the ventilator. One is oxygenation, which is providing oxygen to supplying oxygen to the ventilator. The other one is providing air to the ventilator so that the air and oxygen can be blended and you can adjust the FiO2 from 21 to 100. And then you have two ports. From one, this is going towards the ventilator, towards the patient. Inspiratory port, there it is your endotracheal tube, and the other one is expiratory limb, by which expiratory tubing it is going back to the ventilator, and this is expiratory port. So this is how a ventilator is connected. You can see differently in any different. Again, the mechanism is the same. Inspiratory limb to the endotracheal tube, which is connected to the patient, and other one is expiratory limb, which is connecting to, and at the back you have oxygen port and airway port. And this is your screen. In lower part of the screen, it can be different for different ventilator. You can set the parameters. The above display shows what is going on with the ventilator, like that. Now when you are thinking about the endotracheal tube cuffed, just a small thing about this. This is your endotracheal tube which you use it for intubation. I want to show you one thing. This is your port by which on which the ventilator gets connected. These are the markings. This is a dark black line. This is a cuff, and after intubation you inflate the cuff so that this cuff gets inflated. Now you can see this black mark here. You can see this black mark or any tube, like for that matter, if I take you any tube like this, there is a dark black mark. This is the mark up to which the endotracheal tube should be inserted into the trachea. Means once you are visualizing the vocal cord, once you have inserted the tube, this black mark should just pass through the endotracheal through the vocal cord. That means it is at a safe distance from the carina, and it will not be too deep or too hard. This mark should not. This black mark, it is on every endotracheal tube. If you can see, on every endotracheal tube, this there is a mark here. You see, there is a mark here. So this mark, this mark should just pass the vocal cord so that it's not visible to you. You are seeing the mark, you are intubating the patient, and this mark just, at times it feels difficult that how we can concentrate on different things. But once you start intubating, you start practicing, you will just insert this endotracheal tube and you will be well versed with it. Just this black mark should pass through the vocal cord tube, and it will become it will be at a safer distance. Now this is uncuffed. This is there is no subglottic, sorry, not uncuffed. There is no subglottic section in this endotracheal tube. Subglottic section means these are the tubes which prevents the subglottic secretions, so that VAP is prevented, ventilator associated pneumonia. I'll show you the one thing, subglottic section. Now you see. Uh, huh. If I can show you, this is a more. This is your endotracheal tube. These are the black marks. This is your cuff. Inflate. You inflate the cuff, and this will inflate it. And this is your endotracheal tube subglottic section. By this port remains outside the tube, and through this you can pull. There is a hole, and you can suck out the endotracheal secretions. Okay. So this was all about endotracheal tube. Now this was, we have seen the basic parts of the ventilator. Now there are 4-5 things which you need to understand once we'll proceed for the ventilator, and I want everybody to understand that ventilator is not so difficult. So note down these points. Means if you understand, you can why. Before jumping on to different modes of the ventilator, before oh, we have Dr. Chirag with us from Intellect Medicos, and he is in a very nice person, and he's doing a great job in conducting various courses for the medical students. And really, really very nice, Dr. Chirag, to have you here on the channel. And I'm not very expert like you in conducting these sessions, but we are trying the live stream today so that many of our members can get benefited. Okay, thank you for joining. Now, what I was saying is, whenever you start a ventilator, there are different terms you need to understand. There are various. There are not many. There are the settings, but before that, I want to show you one thing, how a single breath is delivered by a ventilator to the patient. Sorry. Now, this graph is very, very important. All those who are listening should give focus to this graph, because once you understand this, all the graphs, all the phases of the cycle will become very easy for you all. Now, what are the variables in the ventilator? We are breathing, we are initiating a breath, we are holding that breath inside our lung, and then we are expiring. So these are the three forces. We are inhaling, holding the breath, and the way we inhale and then expire. Now, on ventilator, because it's a machine, on ventilator, uh, it's a machine. It has to know how, when it should initiate the breath, when it should start and give breath to the patient. Then how that breath should be given to the patient, what should be the quality of the bread that it should be given, and it should also understand the machine. Something has to tell the machine that it should it should now terminate the inspiration. Like if we start if a ventilator start the breath, it will keep going, but there has to be some mechanism which should tell the ventilator that you need to stop inspiration right now, the patient need to exhale, because exhalation is also passive on the ventilator. So the thing which tells the ventilator that you should start inspiration is called a trigger. So the thing on the ventilator which tells the ventilator that it should start or initiate an inspiration on the ventilator is called a trigger. Very, very important. Secondly, the thing which tells the ventilator you need to stop the inspiration, now the patient need to expire. Important. It is not terminating the expiration, it is terminating the inspiration. So the thing on ventilator, the parameter on the ventilator which tells the ventilator that you need to stop the breath, stop the inspiration and now allow the patient to expire, is known as cycle. You got my point? Any doubt you can ask in the comment. So the thing on the ventilator which tells the ventilator to initiate the inspiration, it tells the ventilator you should now initiate the breath, you should now initiate the breath, that is called as a trigger. And the thing which tells the ventilator now we need to terminate the inspiration and allow the patient to exhale, that is known as cycle. And in between these two, how a breath is delivered, you initiated a breath, and then what will be the quality of breath, whether it will be pressure control, it will be spontaneous breath, it will be volume control, that thing is known as target. Understood? Three things. The thing which tells the ventilator to initiate the breath is called a trigger. The thing which tells the ventilator to terminate the breath, terminate the inspiration, terminate the inspiration is called cycle. And the quality of the breath in between the two means whether it will be pressure targeted or control volume mode or spontaneous mode, the quality of breath, what is, how the breath will be delivered, the quality remain, it is known as target. So these are, and once the patient ventilator has stopped the inspiration, the remaining phase before the initiation of next breath is your expiration phase. Now, whenever you see a graph, whenever you have a graph on the ventilator, how this phase will be presented? This is your baseline. Sorry, I'll take another color. This is your baseline. Here, the breath is initiated. The pressure in the airway rises. The breath is initiated. Till this initiation breath inspiration is going on, and here the ventilator gets a response and now it terminates the inspiration. So it's terminate the inspiration and then this is the expiration, and again this cycle repeated. So there is an inspiratory phase and expiratory phase on the ventilator, and all these graphs we'll discuss, but you need to understand the terminology. The terminology is trigger means the parameter which is telling the ventilator to initiate the inspiration. Target, the parameter on the ventilator which is telling to end the inspiration or terminate the inspiration and allow patient to exhale, is called cycle. And the parameter in between these two which determines the quality of how the breath will be delivered to the patient is called your target. One more term you can call is limit. Target and limit is same, you can call as limit also. You got my point? If this concept is clear, then we'll switch to some more terminologies of the ventilator, which is important. Everybody understood? There are 3-4 things: triggering the breath, limiting, targeting that breath. Then there is cycle, terminating the inspiration, and there is an expiration phase. So these are the 4 phases by which a breath is delivered. If all of you have understood this, we can move to some more terminology. Should I go ahead? I see many people joining from across the world. Thank you. Thank you. Anyone? Everybody has understood what is trigger, what is target, what is cycle. Okay. Thank you. Okay. So now we'll understand some more terminology. So note down in your notebooks or notes which are trigger, target, cycle, and then expiratory phase. So this is how a breath is defined by the ventilator. Now, when we talk about ventilator, there are certain settings we need to set on the machine. So what are those parameters? Just hold on. Let me. Okay. Okay. So what are the different basic window on the ventilator on which you need to set the things on the ventilator? First is your mode. Sorry, why it is not? Which mode of ventilation you want to set? We'll discuss the different which will discuss the different modes. But whenever you set certain things on the ventilator, you need to understand which mode we are seeing. After this terminology, we'll go to the ventilator screen and understand uh, how these are set. Mode means whether it's a control mode, whether it's a assist control mode, whether it's a SIMV mode, or whether it's spontaneous mode. Means what is control mode? Means control mode and the and spontaneous mode. Control mode means, you see, the terminology is very simple. Control mode means ventilator has taken control over the breath of the patient. Means whatever ventilator decides is being delivered to the patients. You understand? What is the control mode? Control mode means patient doesn't do anything. Ventilator has decided, in fact you have decided, you have set the parameters on the ventilator, and those settings are delivered to the patient. Ventilator has patient has no effort. Only thing is ventilator has taken control over the breath of the ventilation. So on control mode, the type of settings which you defined are delivered to the patient. So that's why it is called control mode. I'm keeping my pace a little slow so that everyone who has joined for the first time or listening for the ventilator first time can also get the concept, because we need to discuss the graphs also and then the troubleshooting also. It will be at least 2 to 3 hour session. So we need to very well versed with the basic concepts. So the control mode means ventilator has taken control over the breath of the patient. Whatever is set on the ventilator is being delivered to the patient. Second is your assist control mode. A is written. A means in between if the patient is properly sedated or properly knocked down, that means patient is not generating any effort, then it is a control mode. But suppose the patient start getting awake and he initiates and tries to initiate certain breaths, so ventilator picks that and give the breath to the patient. So that is your assist control. The means now the ventilator is assisting the patient to complete the breath. So that's why it's assist. Usually assist and control mode are synonymous. They on ventilator it is assist and control mode. So if you see C, that means it is a ventilator is providing the total breath to the patient. If it is A, that means patient has triggered the breath and ventilator has provided the breath, but the quality of breath still is determined by the ventilator. Again, I am telling. Control breath means when patient is not doing any effort. Only thing is it is providing ventilator is giving all the breath to patient. Now suppose this patient start getting awake and it initiates a breath like this like this. So ventilator picks that patient wants a breath. Oh, then it says it but provides the breath in a manner which is set on the ventilator. So it will be assisting the patient to complete the breath. It is called assist. So usually A and C are written there. This is assist control. Then you have one more mode which is not very popular but still some use, SIMV. But before that, control breath means volume control and pressure control. So volume control means you have set the fixed amount of tidal volume on the ventilator which the patient should receive, and pressure control means you have set the fixed amount of pressure which will deliver to the patient. We'll see that, but just for right now, just understand that control modes are of two types: volume control and pressure control. We'll come back to that. In SIMV mode, this mode, synchronous intermittent mandatory ventilation. That means now suppose 20 breaths are set and 20 breaths a patient needs on the ventilator. 10 breaths you have mandated on the ventilator that whatever happens, in a minute 10 breaths will be mandatory, will be given to the patient, and the remaining the patient will trigger and will try to take. So intermittent mandatory ventilation, synchronous intermittent mandatory ventilation. SIV means some breaths are ventilator will provide mandatory, and some breaths the patient will take. So SIV, not I'm very fond of this mode, and this mode is get not very much used these days. But you should understand what is SIV. Usually prevalent in the anesthesia part of the world. And now the third mode is spontaneous mode or pressure support mode. In this mode, you are not providing any breath to the means ventilator is not providing any breath to the ventilator until unless the patient is taking. So all the breaths are initiated by the ventilator. All the triggers is coming from the coming from the patient, like this, like this, like this, and ventilator is fulfilling those breaths. So all the breaths are triggered by the patient. That is called pressure support mode or spontaneous growth. Spontaneous mode means spontaneously breathing patient is breathing spontaneously, so it's a spontaneous mode. That's why S is written. Or pressure support modes, you are just supporting the patient. So, and in combination with all these three different advanced modes are there, we can touch them at the end of the session, or we can take in the advanced workshop while we connect with the Zoom. But for the sake of the thing, you need to understand mode can be control mode, SMV mode, or spontaneous mode, or which we call as pressure control mode, pressure support mode. So in control mode, you have set all the parameters, all the breaths. In SIMV, some breaths will be delivered by the ventilator, some will be delivered by the remaining will be delivered by the triggered by the patient himself. In spontaneous mode, all breaths will be triggered by the patient himself, like this. So these are the three modes. So this is the first setting which you in which mode you need to set on the ventilator. Secondly, second is FI2. Very simple. How much is the fraction of the inspired oxygen? FiO2. Fraction of the inspired oxygen concentration. We are. Can I have a few seconds? I need to have some water. You all also can have water in between, coffee, tea in between, because it's going to be 2-3 hour session. Sorry. Second is your FiO2. So once you have decided I will ventilate the patient in control mode or spontaneous mode, now I need to decide how much oxygen I need to give this to the patient. So how much oxygen? It's very simple. We are on 21% of the on room air, and up to 100% you can go on the invasive mechanical ventilation. So it's 30%, 40%, 50%, 60%, 70%. Like that you can decide. It's very simple. There is a knob on the machine by which you can adjust how much FiO2 you can set on the ventilator. Now, so third thing is, what is FiO2? You understood? Fraction of the inspired oxygen. That's the thing. Now the third thing which you need to understand is what will be the respiratory rate. How much respiratory rate we need to provide to the patient. So typically we breathe at 15-16 breaths per minute. That's the average. But depending on the patient requirement, lung condition, like the patient is COPD, or patient is in having ARDS, or the patient is simple post-op patient, or patient is a pregnant female, or obese female, or patient is cirrhotic, different types of respiratory you can say. But respiratory rating setting is very simple. Somewhere vary between 15 to 16 is a normal, 20 to 22 if you want to hyperventilate the patient so that your CO2 can come out of the patient. So respirate, how much respiratory rate you need to set. Fourth thing, in respiratory rate, just understand that why PCO2 is important in setting the respiratory rate of the patient. You can provide oxygen to the patient by simple nasal cannula also. but it will not take care of the PCO2. For PCO2 to wash out from the patient's body, patient need to ventilate. There has to be a diffusion across the patient lungs from the arterioles to the alveoli, because PCO2 is forming inside the body and it has need to get washed out. So you need to ventilate, means this is inspiration, exhalation, inspiration, exhalation. So if the this is called ventilation. Inspire, expire, inspire, expire, inspire, expire. The faster you make the patient hyperventilate, the faster the PCO2, the more the PCO2 will get washed out. So if you are on ABG or you see a PCO2 is rising, it's becoming normal is 35 to 45, but it is now coming 65, 60, and your pH is going down. You need to wash out the PCO2 from the ventilator, and so you need to set respiratory rate a little high. So okay, Dr. Rahman is told that on the ventilator respiratory rate is at times written as F. Yes, frequency of breath. F means what will be the frequency of the by which the patient will breathe. So respiratory rate will be how much will be the frequency. Dr. Priya, you have asked how the trigger should be kept. We'll discuss all this. First, we are discussing the terminologies, different terminologies which are used on the ventilator, so that we can discuss them in detail. So we have discussed trigger, we have discussed cycle, we have discussed target or limit during those breaths. Now discussing terminologies, and once we have understood a few basic terminologies, then we can go to the ventilator screen and then can discuss what are the different breaths, different parameters in detail. So we'll touch all those parameters. So yes, correctly, Dr. Rahman has said. RR is mentioned as F on the ventilator. F means frequency of breath. How much frequency a patient should breathe. So it is helpful in for CO2. How your PCO2 is there. If the PCO2 is high, you need to hyperventilate. If the PCO2 is low, you need to adjust the respiratory rate. Now the fourth thing which you have decided what mode should be there, how much FiO2 should be there, how much is the respiratory rate. This depends on oxygen concentration in the blood, FiO2. Fourth is your what will be the target. Target means how the breath will be delivered in volume control or pressure control. Means you need to decide either the tidal volume or pressure. These two things. Now understand. In volume control, we have set ki what is the tidal volume? Is somewhere around 450 to 500. The amount of air which goes inside and outside of the lung during one breath, that is called your tidal volume. Is somewhere around 450 to 500. The usual one is 6 to 8 ml per kg weight. If the lung is not in ARDS, in the ARDS lung we keep it 4 to 6 ml per kg body weight. Important, it comes in your exam, you can note it down. In ARDS, how you set the tidal volume? 4 to 6 ml per kg body weight. And in the normal lungs, not ARDS lung, 6 to 8 ml per kg body weight. So suppose if your patient is 60, 70 kg patient is there, so 6 to 8 ml means 7 6 42, I think 422, between 420 to 500 will be fine enough. So this is how you set the tidal volume on the ventilator. Now if it is a pressure support, pressure control mode, you cannot set the tidal volume. What you need to do is you need to adjust the pressure so that your tidal volume gets that range. You adjust you provide that much amount of provide that much amount of pressure from the ventilator, then you your tidal volume gets generated based on that ventilator, and then we can adjust the pressure in a way that your targeted tidal volume is generated. So this is your uh, this is your how the target is generated. Sorry, at times you you may feel that I get fumble or I get stopped, because I'm reading the comments also, so that I can take all those comments. Like Dr. Srinil also has a very good question. We'll take that. So first we cover up, we'll finish off this terminology. So you have set the mode FiO2 respiratory target. Now one more thing, trigger. Trigger. What will it trigger on the ventilator? How it will be generated? So trigger can be of flow and pressure. Will I'll explain right now itself. What happens? What uh, what happens? There is a circuit. You have a ventilator. The inspiratory limb is coming towards the patient, getting connected to the ET tube. The patient is exhaling, and there is an expiratory limb which goes towards the ventilator. This is the circuit. Now, how the ventilator will know that I have to trigger the breath? There has to be some mechanism which can sense the patient effort, like this. If patient wants to take the breath, it will suck the air like this. Obviously, this will in the case in which a patient wants to start the trigger. So what happens in that circuit? Whenever a patient is initiating a breath, the pressure in the circuit falls, or and that the patient sense, that is called pressure trigger. Means there will fall in the vacuum will created, and there will fall in the pressure in the circuit, and now the ventilator will sense, oh, there is a fall in the pressure, I need to provide breath to the ventilator. These trigger sensors are located on the expiratory limb of the patient. Expiratory limb. Let me I'll draw you and show you. Sorry. Suppose this is your ventilator, and suppose this is your ventilator. This is your inspiratory limb, and this is the patient. This is patient, and this is ventilator. And it goes to the patient, you know, and this is your expiratory limb. Just this is inspiratory limb, and this is expiratory limb. Now, suppose now we have discussed the pressure wala, and now we'll discuss the trigger. Now the flow. Now there is a constant flow of some amount of air in the circuit, in the this ventilator circuit, which we call as bias flow. So suppose there is a 10 ml. There is a 10 ml flow which is constantly in the circuit of the ventilator. It is going like this, like this, like this, like this, like this, like this, and it is यहाँ पे there is a sensor. Here it is the sensor which is picking up how much flow is coming. It's 10 ml. So what is happening? A constant flow of 10 ml is going on, and this inspiratory wall is giving 10 ml of flow, and the expiratory wall is sensing 10 ml flow. So there is no breath, no patient effort. That's why there is no patient trigger. But suppose this patient gets awake, and it sucks the air. So what will happen? This flow will get diverted towards the patient. So there, suppose the patient sucks the flow at the rate of 3 ml. So out of this 3 ml goes towards the patient, and the remaining which was going towards the patient ventilator is 7 ml. So now this expiratory wall sense, oh, the flow which was coming to my to me has decreased by 3. So now that means the patient is getting awake. I need to provide breath to the patient. The patient has triggered a breath. Now I have to provide. So this is a flow trigger. So the amount of flow from the inspiratory wall is coming, and that is getting sensed by the expiratory wall. Now, if the patient initiates a breath like this, the flow get diverted towards the patient, and the flow which is reaching to the expiratory wall has decreased, means some portion is diverted towards the patient. So that's why now the ventilator sense that patient has triggered. So trigger can be of two type. One is your flow trigger and the other one is pressure trigger. For 99 or 95% of the patients, flow trigger is used, and it is used to minus 3 ml sort of thing. We'll see on the ventilator scheme. And on pressure trigger, the pressure drops in the circuit. Usually it comes handy in older ventilator, on which whenever you nebulize the patient and you connect the ventilator, you connect the nebulization to the inspiratory limb of the ventilator. And what happens, ki, though the patient is triggering the breath, but the extra flow is supplemented by the nebulization machine. So the expiratory valve receives the complete flow. So it doesn't sense that patient is triggering. Then you need to switch the flow trigger to pressure trigger. We'll see this. Sixth thing you need to understand is PEEP. Pay attention to this for 2-3 minutes. Pay attention. What is the full form of PEEP? PEEP means positive and expiratory pressure. That means a pressure applied to at the end of expiration. Positive and expiratory pressure. Like, I'll give you this example of the balloon. Lungs are like a balloon, and it's very easy to provide example when you talk in terms of balloon. Suppose you are blowing your balloon is your alveoli. You stretch the balloon and blow the balloon like this. You have blown up the balloon, and now you release it, and you don't tie that with a thread, or you don't put a knot on this, and when you release, the alveoli will collapse. Barabar? So when you blow a balloon and if you don't apply any pressure or anything at the end of blowing up the balloon, it collapses. But now what happens? You blow the balloon like this, and you immediately put a knot or thread on the balloon. Now if you even release your inspiration, the balloon will not collapse, because there is some pressure which is applied at the end of expiration. So that's why PEEP is that thread or knot which is applied at the ends of inspiration or at the end of expiration. So positive and expiratory pressure means when the balloon is trying to collapse, the alveoli are trying to exhale, alveoli are trying to collapse. There is a pressure above there from the ventilator which doesn't allow the alveoli to collapse. So positive and expiratory pressure is a pressure which is applied at the end of expiration and which helps the alveoli to don't collapse. Otherwise, they will collapse like this. So PEEP doesn't open the lungs, or PEEP doesn't open the alveoli. PEEP only keeps the lung. PEEP prevents the lung from getting collapsed. Just 1 second. Sorry. Okay, so PEEP means positive and expiratory pressure. So PEEP doesn't open the lungs, because the opening of the balloon is done by your blowing inspiratory phase. But PEEP prevents the lung from getting collapsed. It is applied at the end of expiration, so that your while exhaling the alveoli doesn't collapse. This is very very important when we'll discuss the ERDS. So a PEEP doesn't open the lungs, but it prevents the lung from getting collapsed. So these are the some terminologies which you have understood. These are the terminologies which you have understood. One is mode, FiO2, respiratory, target, trigger, and P. So now what we'll do, we'll go to the ventilator screen and see how these are demonstrated. If I could zoom. Okay, so see this. This is a ventilator machine. Okay. Now, what is the mode? So this is control mode. You understood? This is A. This, what does this A showing? It's an assist mode. Means the patient is in control mode, but like this. You see, this is C, the type of mode which you have set on the ventilator. This is control mode. Previously was assist control mode. Now FiO2. This is your FiO2 percentage. What is the type of how much FiO2 you need to give this patient? 60%, 70%, or like this. This is the mode which is saying assist control modes. Control means full breath patient is everything ventilator is delivering to the patient, and assist means if the patient starts a breath, ventilator will supplement. This is your breath. Respiratory rate 15 per minute. 15 per minute. One doctor told that it is a um, frequency. F is written. How much the breath the patient should take per minute. So this is frequency. Now this is tidal volume. This is your tidal volume. It's at 500 ml per minute. Now this is your trigger. It is set as 3 liter per minute. Means if the flow in the circuit decreases by 3, then the ventilator will sense. This is your PEEP. How a PEEP is set on the ventilator. So these are the mechanisms. These are the basic settings which you need to understand. You need to set on ventilator. How you set? How you set? Sorry. Oh my, I'm not. This is how you set which mode you need to select is assist control mode, SIMV mode, or spontaneous mode. Then you need to set what is the mode you need to set, if pressure control or volume control. Then trigger, whether you need to show. Now you can see just a very interesting thing you need to see this. Do you see any difference between this V? Sorry. This V here and this V here. One is V and one is V and with a dot in it. Okay. So V, the simple V means volume, and the V with a dot on it means flow. Flow. So here you can see this trigger. V with a dot in it, it's showing flow trigger. It is not pressure trigger, it's a flow trigger. So that's the thing. Where we are where we are discussing. So you see, this is flow trigger. Only two types of trigger are there in patient. This is flow V by a dot in it, and this is a pressure trigger. Okay. So these are the things. These are the minimal settings which you need to understand. That these are the terminologies we have done 1 hour. So we have what you had understood. We had different phases of ventilation, different terminologies which we need to understand, basic understanding. And now we'll get serious. We'll go into the details of um, different modes in detail, like that. Shall we proceed? If you have any doubt, you can. I'm halting for 1 minute so that if you have any doubts in the session so far, you can ask me. FiO2 ratio, okay. Pressure trigger is Dr. Khudabaksh have asked from Pakistan that what is the difference between pressure trigger. Pressure trigger is also the same. The amount of pressure change in the inspiratory limb, which is sensed by the expiratory limb. If the pressure falls because the patient inhales, there is a fall in the pressure. That pressure is fallen, and you can set that on the ventilator. It's more or less same like flow. How do we set PEEP? Okay, usually the normal peeps is usually physiological peep is somewhere between 3 to 5. you need to say in ARDS you need to increase so that oh yes, Tannoy, very important. And in ARDS you can increase the PEEP so that the lung doesn't collapse, because ARDS lung tends to collapse, and therefore you need to increase PEEP from 5, 6, 7, 8, 9, 10 up to, I have gone to 22, but somewhere 15 is the usual one in ARDS which is kept there depending upon the lung pathology. Also, mm, um, in subcardiac failure patients, you need to provide a more positive pressure ventilation. The lungs are parenchyma is filled with the fluids, so that and the alveoli tends to collapse. So PEEP of 6, 7, 8 in pulmonary edema patients also we can do. So that's the thing. Okay. Now, very important. I appreciate Dr. Tanoy Paul. Very important question he has asked, and I need to address this. One thing which I left is IE ratio. Very. Before discussing the I ratio, Khudabaksh again use when do we use pressure trigger? So pressure trigger we don't use normally. For 99% of the cases we use a flow trigger. But what happens? Just to answer your question, uh, suppose this is your ventilator. Sorry, this is your ventilator. This is your inspirator. We are discussing the pressure trigger. Uh, this is your patient, this is your inspiratory limb, and this is your expiratory limb. ठीक. Now suppose you have a patient who is on the flow trigger. Okay, so here 10 ml flow is going from the ventilator, expiratory valve is sensing 10 ml. Now this patient sucks 3 ml of the 3 ml of the flow, and now what happens? This flow gets decreased by 3 ml, which is sensed by the expiratory valve as SAML. Okay, so now it sensed that, oh, my patient is triggering the breath, I need to get. So this is flow trigger. Now what happens if you add a nebulization here? You add a nebulization machine here, and the nebulization is giving nebulization to the patients. So even in that condition, if the patient is sucking the air, the flow is getting decreased. This nebulization machine is supplementing that thing, and what the ventilator, the expiratory valve receives 10, again 10 ml or 10 to 11 ml. So it will feel that, oh, the flow is not decreased, patient is not triggering, it will not trigger the breath. So in that scenario, whenever your patient is on nebulization, you can switch the flow trigger to the pressure trigger. So this will help to compensate for that mismatch due to nebulization machine. But the newer ventilators which are there, they have a mechanism to understand this. So for practical purposes, we always keep the patient on the flow trigger. Okay. Now coming to what Dr. Tanoy was discussing, asking that I ratio. Sorry, this thing I forgot to mention. Very important. Now I ratio is really very simple. Really very simple. Inspiratory expiratory ratio. Now we are having 60 minutes, 60 seconds to take a breath, in 60 seconds in 1 minute, and suppose we take 15 breaths in those 60 seconds. So every fourth second we are taking one breath. So suppose 60 seconds are there, and we are taking 15 breaths. Okay, so 60 divided by 15, every 4 second. Every 4 second we are taking a breath. Now in this 4 second, we take 1 second to inspire and 3 second to exhale. So our inspiratory expiratory ratio is 1:3. So we are taking 1 second to inspire and 3 second to exhale. Now what is the importance? inspiratory phase helps the oxygenation to get in, expiratory phase gets the PCO to get washed out. Correct? Clear? Again, inspiration helps the oxygen to get in, and um, ex- expiratory phase lets the PCO2 to get washed out. So that's the normal. Some people use 1 is to 2 as a normal one. Usually in the anesthesia, they give 1 is to 2 ratio and then decide. Now, what will happen if you decrease this expiratory phase? What will happen? Uh, if you decrease the expiratory phase, the CO2 will not be able to come out of the patient and your PCO2 will rise in the patient's blood. Inspiration will become longer, inspiration will increase, so oxygenation will improve, but if our expiratory phase gets shorter, the PCO2 will rise. Now if it is 1 is to 3, if it is 1 is to 3 normal, even for normal lung, 1 is to 3 or 1 is to 2 don't make a change. But the questions becomes important when you deal two types of patient. One is ARDS and the other is COPD. In COPD, the problem is with PCO2. PCO2 is not able to come out because its airway are inflamed and carbon dioxide is getting retained. So in COPD, what happens? You need to increase the expiratory phase. So you can go to 1 is to 4 or 1 is to 5. This will allow the more CO2 to get washed out. So in COPD, you need to do get an inspiratory expiratory ratio 1 is to 4, 1 is to 5, so that it allow more CO2 to come out. While if you reverse it, if you come like 1 is to 1, what will happen? Though it will decrease the amount of exhalation times, your PCO2 will rise, but inspiration will increase. Now it will be 30 seconds inspiration, 30 seconds expiration. So 1 second for inspiration, 1 second for expiration. Though it will decrease the expiratory phase, but inspiratory phase will increase like this. So more oxygen will go into the lung. That's why in ARDS at times they reverse 1 is to 1 or 0.8 to 1 like this. Oh, sorry, 1 is to 5, sorry, like 1.5 is to 1 or 2 is to 1. But we don't go there, we remain as 1 is 2. So that is called your reverse inverse ratio. Reverse inverse ratio means in normal patients, expiratory phase is longer, inspiratory phase is shorter. But when you reverse it in ARDS, you make inspiratory phase longer than the expiratory phase. It calls inverse ratio ventilation, and it helps the oxygen to go there in the lung and remain there for a longer time at the cost of retention of PCO2, and that's why we call it permissive hypercapnia. We are allowing the PCO2 rise in the patient because we want the patient to get oxygenated, otherwise he will collapse. So that is inspiratory expiratory ratio. Normal is 1 is to 2 or 1 is to 3 for normal lungs. In COPD you need to go to 1 is to 4 and 1 is to 5 because you need more PCO2 wash out, and for ARDS you go to 1 is to 1 or slightly reverse it so that your oxygenation improves and at the cost of permissive hypercapnia. So I think that is clear with I ratio. Thank you, Dr. Tanoy. Okay, one very important question. What is the difference between uh, what is the difference between a assist breath on control mode and the breath which is known as in SIMV mode? What is the difference? I am not but cute couple cheeky bubble. This is the name of the user. Where is it? Okay. Adil also asked reverse I ratio. I think it's clear. It's an ARDS which we use. Huh. Okay. Somebody has asked before we jumping to that breath question, how do we find the I ratio on the ventilator? Very nice question. It's there on the ventilator. See, here it is. I ratio. It is 1 is to 1.5. It's on the screen. You know? In any you see here 1 is to 1.5, 1 is to 1 is 2, 1:2, 1:3. You can go on the ventilator scan, it is written there. Okay. Now what the question was, what is the difference between a breath in the assist control mode which the patient triggers and on the SIMV mode? So one thing very important, in control mode, if the patient triggers a breath, then though the patient has triggered a breath, and now the ventilator will provide, sensing that patient has patient wants a breath, and now we are providing breath to the patient. Ventilator is providing breath to the patient. But in control mode, the quality of breath is not altered. If I have set a tidal volume of 450, if I have set some pressure, that means even if the patient has triggered a breath, the ventilator will provide only the type of breath which is set on the ventilator. It will not alter. While on SIMV mode or pressure support mode, okay, I missed the pressure support mode, I think, to explain. Okay, I'll cover that. In pressure support mode or SIMV mode, the patient will trigger a breath, but the amount of tidal volume getting generated in the lung will depend upon the patient's effort. It will not be set by ventilator. So in assist control mode, even if the patient has triggered a breath, the quality of breath will be pre-decided by the ventilator. I will provide this much amount which I have been told or set on the ventilator. While SIMV or pressure support mode, uh, the patient triggers a breath, and the quality of breath will be divided by, depend upon the patient's respiration, patient's effort, like that. So this is the thing. Uh, I missed the pressure support mode or CPAP mode or NIV mode on the ventilator. I'll explain you this. Now, suppose I'm taking a breath, the patient is taking a breath, like this. So there is certain amount of air which goes into the lung. If we inspire deeply, now the more amount of air goes into the lung. So that depends. The same if we switch for the ventilator, means if I put a less effort, less amount of air will go inside the lung. If I put a deep effort, then the more amount of air will go inside the lung. So in pressure support mode, based on the patient effort, like this, and we have set on the ventilator that the ventilator will provide 10 pressure support or 12 pressure support, only this much pressure support. Based on that pressure support, how much amount of tidal volume will get generated depends upon the patient lung mechanics and the patient's effort. Okay, that is the pressure support mode. Tidal volume will not be set, only the pressure support. How much support, now patient trigger this much effort, and the pressure, if 12 is there, ventilator will supplement this pressure, and combination of the will generate a tidal volume to the patient. So that tidal volume will depend upon the patient effort and the pressure support which is provided by the ventilator. So the, the pressure support can only provide some support to the patient based on which the tidal volume generated. How you should set that pressure support? It should be like that, so that you achieve a good tidal volume, like 450, 460, 470, that much mLs, that much amount of tidal volume you should get on the ventilator. So that's how you set the pressure support. Normal is 5 to 10. If it is requiring more than 10, 12, 15, that means patient is still requiring some support and it's not in a position to get extubated or TP trial for the patient. One more important thing, minute ventilation. Minute ventilation is important. Minute ventilation is nothing but tidal volume into respiratory rate. How much amount of the breath, how much amount of the volume of air is going with each breath into the respiratory rate, so that in a minute how much amount of air total moves out in out of the lung. Why it is important? Because if the minute ventilation goes down, your PCO2 will goes down. Ventilation, whenever you are asking about ventilation, talking about ventilation, we are talking about CO2. So if minute ventilation get decreased, patient will start retaining your PCO2. If the minute ventilation is high, then your patient will getting washing out of PCO2. So this was the basic terminology about a ventilator which we need to understand. And now we'll move on to how a breath is delivered to the patient. What are the triggers? What are the modes? What are the different terminologies? And so now we'll start with that. Any question till now? So I think reasonably in a 1 hour time we have covered the different terminology, basics of ventilation. Now we'll discuss the different modes, airway resistance, compliance of the respiratory system. What are the different modes? What is the difference between different modes? And then we'll understand different uh, peak pressure, plateau pressure, all these graphs and all. Combination of these graphs, and then we'll go to troubleshooting. So next 35-40 minutes will be important. You need to continue with that, or you need a 2 minute break. If you want 1 or 2 minute break, we can break it. But now the next 1 hour is very important, because in this we'll be discussing the different compliance of the lung. Different compliance means different terminology, compliance, resistance, modes. Just let me know if you want 1 or 2 minute break, or we can continue. Are you able to understand? You want me to go a little faster, or the pace is fine? Because we are, um, uh, we need to sit for next almost 2 hours more. Let me know if I want to be a little faster or little slower. Just let me know in the comment section. Okay, so it's 11:19 on my side. 2 minutes break, and we'll resume it in. Okay, 2 minutes break. 2 minute break for me. Me also. Because now we will discuss something serious. Just give me 2 minutes. I'll coming back. 2 minutes. Okay, so now we'll start. So there are a good amount of people on the channel right now. Next time I'll provide you for selected members. We'll provide you the links for Zoom also, so that few 60 70 people can be connected to me with Zoom also, so that we can discuss live also. Now we have discussed, basically till now we have discussed how a ventilator needs to be set, how this ventilator provides the breath, but what is happening, you have a patient and your ventilator is providing breath to the patient, something is going to change in the patient. Now the patient respiratory mechanics comes into play. What is the status of the lung, how is the compliance of the lung, how is the resistance of the lung. It's not simple. Like I'll give you an example again. Balloon is my favorite example. You purchase some balloon on this birthday and you blow the balloon and the balloon will blow up very nicely. Now if you some balloons remained and you kept those balloons, and on the next year, next birthday, you open up the lung balloons. Now you start to blow them up, but now they will not, it will not blow up so easily. It will not blow up so easily. So now the mechanism, something has changed with the balloon. They have become more sticky, they have become more what you say, more resistant, and it's not easy to change the blow up the air. So now something has changed in the balloon. The that's why are the different. This is how the different lungs of different patients. So once the ventilator has certain parameters and started to providing the breaths to the patient, the lung mechanisms of the patient comes into play. Based on that, you need to understand certain terminologies, and based on that, you need to understand certain graphs. So let's jump to them. First, we'll understand the concept of resistance and compliance of the system. Very, very important. And let's see. Uh, okay. How to zoom it? How to zoom it? Okay. I seems it's looking nice. Now, why am I using Chrome or web browser? Because I want to tell you that if you stuck in something, the data is so much available on the internet that if you get a reliable resource, you can read very comfortably. So for that, why I'm not used PPT. I'm trying to explain why the things available on the net so that it becomes easy for all of you to come. This is a normal lung, है ना? Before jumping to that, explain you by face. You take inspire some air into your lung, then you have a airway pattern, airway in your lungs, the trachea, the bronchus, right and left bronchus, then you have three lobes, then you have different respiratory bronchioles. This is the airway part of the system. Once they reach the terminal bronchioles, they have different alveoli. So that is the parenchymal part of the uh, this is the different parenchymal part of the lung. So airway part of the lung and parenchymal part of the lung. So the airway doesn't blow up, but they conduct the airway air from ventilator to the alveoli. Alveoli doesn't conduct; they need expand and collapse. They expand and collapse. They expand and collapse. So they they are more stretchable or less stretchable. That's why you see that is called compliance. Let's see what I was trying to explain you in the Chrome. This is your normal lung. This is your airway. Just for the sake of simplicity, this is a beautiful diagram. This is your airway and this is your lung. So the resistance which the airway provide, the means the obstruction or some what you call the pressure or the resistance, the pressure which the airway resists or provides to the ventilator to conduct the air from ventilator to the patient is called resistance. And the stretchability, how easy is the lung is able to expand and collapse is called compliance of the lung. When we are talking, so when we are talking about the resistance of the system, we are basically talking about the airway. Very important. You can note it down. Raise what is resistance and what is compliance of the system, because when we'll discuss the graphs, they all will come into play. So if we are talking that the resistance of the airway, resistance of the patient is high, we are essentially talking about the airways of the patient. If we are saying that we are talking about the compliance of the system, compliance increase or compliance decrease, essentially we are talking about the parenchyma of the patient, alveoli, at the alveoli level, which we are talking. So if I tell you that the resistance of the patient has increased, means there is a bronchoconstriction, there can be tube can be kinked, or you have used a narrow endotracheal tube, or there is a plug in the mucus plug in the airway, or foreign body in the airway, or water in the endotracheal tube or HME filter. So anything which is obstructing the flow from the ventilator to the parenchyma because of this airway will increase the resistance of the system. So essentially when we are saying that if airway resistance is increased, we are talking about the airway. That's why it's called airway resistance. Now compliance, stretchability, how easily you can stretch. How easily can you stretch? So the compliance of the balloon which you open on this birthday was normal, but the compliance of the balloon which you kept for 1 year then tried to expand, means the compliance is decreased. Now patient lung is not stretchable, balloon is not stretchable, it is restricting, it is opposing to expand. That is called less compliance. See, so whenever you're talking about the compliance of the system, we are essentially talking about the parenchyma of the system. So resistance and compliance. There is one more diagram which was very good here. You like this. You see, if there is a problem, resistance problem, that means essentially there is a problem in the airway. If there is a problem in the compliance, we are talking about the uh, parenchyma of the problem. You got my point? Okay. Okay. So resistance means airway problem, compliance means lung problem. Again, example I am giving you to make you more clearer, because some of the people are there which are very new to the ventilator. Because you need to understand this concept, because all the graphs are based on all this only. If you understand this, every graph will become so easy. I'm telling you, ventilator is one of the easiest thing which you come across in the ICU. Okay. So airway resistance means from the airway to the parenchyma, this airway is conducting the tube. But when you take on the ventilator, from the ventilator, there is a ventilator circuit, then you have HME filter, then you have endotracheal tube. This will also come under the airway. So any problem in this circuit, then endotracheal tube, HME filter, your airway, like bronchoconstriction, mucus plug in the airways, foreign body in the airways, water in the and excessive condition in the HME filter, or biting of the tube, or blockage of the tube, clots in the endotracheal tube. All this will give rise to increase in the airway resistance pressure. Airway resistance will increase. Now, if we talk about if so, we need to address the what are the causes, and then the resistance will decrease. Now, If there is a fall in the airway resistance, what is the most common problem? Leak in the circuit. If there is a leak in the circuit, there is a hole in the tube, or something has dislodged a tube disconnection, then the airway resistance will fall. This is one of the two most common causes of fall in the airway pressures suddenly. But the problem which comes again is increase in the airway pressure. Now, when we talk about uh, compliance, compliance means, which essentially we are talking about the lungs parenchyma. Lung parenchyma means it includes your lung and also as well as the pleural space. So if the lung is not stretchable, you cannot, you lung is not compliant, means you blow air and it is not compliant to take that air, not stretching, like um, interstitial lung diseases, like your pulmonary edema when the alveoli is filled with certain things, ARDS, then pleural effusion, which is pressing on the alveoli, atelectasis, alveoli gets collapsed, pulmonary hemorrhages, where the alveoli get filled with your blood. So these things will decrease the compliance. Means the lung is not in a position to expand. It will not open up so easily. So decrease compliance. Okay. Increased compliance usually you've seen in COPD patient. It gets stressed, but it will not collapse. Problem is in the airway in COPD patients. The compliance increase. It will, you blow air, it will fill like this. But the problem is it will not able to exhale that air. So that's the thing. So airway resistance and compliance. One more thing which is very very important, and most of the candidates or students which I come across gets confused in, is the difference between compliance and elastance. Elastance is just opposite of compliance. So if I say compliance is change in volume per unit change in pressure, you blow something and how much the volume is changed, it is called compliance. And elastance is change in the pressure per change in the volume. How much the lung will resist to is, and come will the, to the backward position when a volume is changed. So a less compliant lung means it is not stretchable. A more compliant means that it can be stretched very easily. Elastance means you have seen the elastic, you it gets expanded and then collapse. So what you need, what students remember is the stretchability as the elastance. No, it's the recoil, elastic recoil, which you consider as elastance on in the lung. The stretchability is compliance. Sorry, how easily you can stretch it, it's compliance. But how quickly the lung gets back to normal position is your called elastance of the lung. So in like your interstitial lung disease, where the lungs are getting fibrosed, so it is getting very difficult for you to blow the air and expand the lung. So compliance has decreased. But the moment you release the pressure, it comes back to normal, because it tends to remain in its normal position, neutral position. So elastance has increased in interstitial lung disease. In COPD patients, what happens? You blow the air, they expand. So the compliance has increased. But the problem is it doesn't collapses because of the alveoli are so hyperinflated. It will remain there. It will not collapse because airway resistance is high. So the elastance has decreased. It is not coming back to its normal position. That's why its PCO2 is not able to come high. So that is the elastance and that is the compliance. So airway resistance means we are talking about the airway problem. If we are talking about the resistance, we are talking about the airway problem. If we are talking about the compliance, we are talking about the parenchyma, stretchability of the lung. If we are talking about the elastance of the system, means how quickly the lung can get back to its normal position, elastic recoil of the lung, that is called. So um, that was I think everyone clears. Mention in the chat box that you have understood airway resistance, compliance, and elastance, because it is very very important. All the graphs which are coming will discuss will are based on these only. All the respiratory mechanisms are based on these concepts only: resistance, compliance, and elastance. Once you understood this, then we'll discuss peak pressure, plateau pressure, and all this. Just let me know in the chat box whether you have understood these three concepts: resistance, elastance. Oh, sorry, resistance, compliance, and elastance. Waiting for you to comment. Okay, so the comments started coming. Yes, understood. Vinay, AA, Virat, understood. Very nice. Very good. Aditya, thank you. Nicely explained. Okay, Ajay. So I think this is everybody has understood. Most of you have understood. I am able to convey point: resistance, compliance, and elastance. Now, again going to that Chrome window. Where was the previous diagram? Huh. So, mm, before jumping on to the graph portion, because graph portion and the different scenarios, lung respiratory mechanics will go hand in hand. Now, I have told you the airway resistance. When we are talking about the airway, we call this a resistance, and where we are talking about the parenchyma, essentially we are talking about the compliance. So, but the but for ventilator who is giving breath to the patient in one single breath, it has to overcome both the things. It has to overcome the resistance and it has to overcome the compliance to give a single breath. So that is the total airway pressure. If we call this the total airway pressure, it is a combination of your resistance and it is combination compliance. So total airway pressure is resistance plus compliance pressure, or you can call it elastance pressure. So resistance, how the airway is providing pressure, and how the elasticity of the lung, because elasticity restrict the opening up. Compliance helps in opening up, but elasticity tends to prevent the lung from opening. So what we call is the total airway pressure which a ventilator needs to overcome during a single breath is your resistance pressure plus elastance pressure. Why not compliance pressure? Because compliance is helping the lung to open. It needs not to overcome. Elastance is something which is restricting the lung and it is preventing the lung for coming to the neutral position. So the equation becomes like this. I'll show you because this equation will come handy in all the things. So the total total airway pressure, or we call it positive air pressure, the pressure which we ventilator is providing to the lung, is equal to your resistance pressure plus your elastic pressure. Correct? How much resistance it has to overcome and how much elastance it has to overcome. So this resistance pressure is flow into resistance. Why this is dependent on the flow into resistance? This is total pressure. Suppose you have a tube, you have an endotracheal tube of, for example, I am not commenting on the airway, endotracheal. Suppose a endotracheal, you have broad endotracheal tube of 8.5, and you blow with a certain force, like this. Okay, fine. Now you have endotracheal tube, narrow endotracheal tube of 6, and you now flow the same amount of. Now there will be more resistance because the narrow endotracheal tube will not allow the air to pass so easily. So resistance depend upon resistance of the system, endotracheal tube or like that. It also depends on the flow. Now you have a same endotracheal tube. You have an endotracheal tube of 8.5, and you flow and you blow like this. Okay, but if you made the if you blow very forcefully like this from the ventilator, now the flow is high. So if the flow is high, the airway will raise. So that's why the resistance pressure depends upon the resistance of the system and the flow which you are providing. So the raise, if you need to reduce the resistance, either take a broad endotracheal tube, or if there is bronchospasm, give a bronchodilator, or decrease the flow on the ventilator. So total airway pressure depends upon resistance pressure plus elastance pressure, but resistance pressure depends upon flow and resistance of the tube. Basically, here is your endotracheal tube, your tube circuit, your that is a bronchoconstriction, like that. And flow, how much flow you are providing from the ventilator. If you provide more forceful flow, there is more resistance. Like in COPD patient, if you need to overcome resistance, at times you need to decrease the flow, like that sort of thing. Now, secondly, this total airway pressure will depend also on elastic pressure, because the lung tends to recoil forcefully, and it is the formula for this is tidal volume upon compliance, elastic pressure, tidal volume upon the compliance of the patient. So the more tidal volume you provide to the system, suppose you are providing a 400 and to other patient you are providing 500. So the more tidal you providing, it for 400 elastic pressure will little, but you provide 500, it will tends to recoil. Chitta elastic, the more you pull the elastic, the more force it will come back. If you stretch like this, it will recoil, but you stretch like this, it will come very quickly. So elastic pressure depends upon the tidal volume, directly proportional to the directly proportional to the tidal volume which you are providing, and it is inversely proportional to the compliance of the system. Because if the lung is very compliant, like in COPD, it stretches like this, so it will not come back. So if the compliance is high, the elastic force will be less, so it will remain inflated, so pressure will low. But if like interstitial lung disease, where there is fibrosis of the parenchyma, you cannot, the compliance is less, so the elastic pressure is high, means it will raise the chain. So elastic pressure will depend upon tidal volume upon compliance. If I tell you there is a one equation by which you can solve all the graph, then this is the equation. You can note it down, you can put it on your notice board, you can put it on your mobile wallpaper, you can write down anywhere. If you understand this equation, everything about the ventilator graphs or troubleshooting you will understand. Everything. There is not even a single question, there is not even a single concept which you can miss if you understand this. I assure you. So, total airway pressure at the start of if a ventilator towards the patient depends upon the resistance pressure of the airway and the elastic pressure of the parenchyma. Resistance depends upon how much resistance the airway is providing, and how which with force flow you are providing the breath. Elastic pressure will depend upon how much tidal volume you are providing, and inversely proportional to the compliance of the system. Okay? So I think this is very clear. I want each and every to comment in the chat box that you have understood this equation. Very, 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 very important. One equation which will solve all the queries. Total airway pressure is equal to resistance pressure plus elastance pressure. Resistance pressure depends on the flow and resistance of the system, plus elastic pressure is directly proportional to the tidal volume and inversely proportional to compliance. You understood this? Post in the chat box that you all understood this. If you don't understand, I'll explain 100 times this equation. Okay, Anant saying yes. Be safe saying yes. Sibatin saying yes. Akhtar, Medico, very nice, very nice, very nice. So those who are interacting, na, they will get benefited from Dr. Sagar Jaswant. Oh, from UAE, Jaswant, very nice. Welcome, Jaswant. So those who are interacting, they will get a chance to connect live to the Zoom in the next session, so that we can discuss also. Just hold on. Okay. So that's clear. Now this thing, this is also known as alveolar pressure. Just for the record, you need to understand. By writing is not good. Tidal volume upon compliance is also known as alveolar pressure. So if I take uh, okay, I'll not confuse you all, but we'll discuss, because if you reshuffle the situation, it can also get positive area pressure minus alveolar pressure equal to resistance pressure. I think I will not discuss this. You will get unnecessarily confused. Flow into resistance, just to make you understand that we can rearrange in a situation positive airway pressure minus the alveolar pressure equal to flow into resistance. This is used for calculation in the exams, that's why I have mentioned, but it's fine even if you don't understand. Now we'll discuss about something about graphs. We'll touch the graphs and we'll see the graphs. Just give me a second. Loops. Flow volume loop. Okay. So we have understood what is the resistance, what is the compliance of the system, what is the elastance system. Now we are slowly moving to understand the graphs. So for the graphs, because when we understood the graph, when we'll go to the graphs, these all three parameters will come into play. Okay. So there are only 5 graphs on any ventilator. Any ventilator you go in the world, they will only have 5 graphs. Out of those 3, out of those 5, 3 are called scalars because they are mentioned across a time scale. Okay. And the 2 are loops. Understood? So there are only 5 graphs total on the ventilator. Out of those 5, 3 are called scalars and 2 are called loops. Why are they scalars? Because on time scales we mention those things, parameters. There is a one parameter mentioned on the time scale. So these are called scalars, and 2 are loops, which is pressure volume loop and flow volume loop, by which we post the 2 parameters, one on axis and y-axis, and make the loop. So understood? 5 graphs, 3 are scalars, 2 are loops. And there are only 3 parameters by which all these graphs are made. One is your pressure, second is your flow, and third is your volume. That's all. Nothing else. Only 3 parameters. 5 graphs, out of 5, 3 scalars, 2 loops, and only 3 parameters, 3 variables. Right? Your pressure, flow, and volume. So what will be the graphs will be? Pressure scalar, pressure on the y-axis, time on the x-axis. Flow scalar, flow on the y-axis, time on the x-axis. Volume scalar, volume on the y-axis and time on the x-axis. 3 graphs, scalars. 2 loops, volume is there. Volume is common in both the loops. So pressure volume loop or flow volume loop. That's it. Those are the 5 graphs. So again, because you people love this iPad, there are only 5 graphs, 3 scalars and 2 loops. Okay, scalar means we are mentioning one parameter across the time scale. So that's it. Only 3 variables are there by which all these graphs are um, all these graphs are made. One is, what are the 3 scalars? One, pressure, sorry, pressure time graph, so pressure scalar, क्योंकि one is always time in scalar. Second is flow, which is mentioned by dot in the V, and third is volume. Clear? Two loops. One is pressure volume loop. There is no time in it, and there is flow volume loop. That's all. These are the 5 graphs which you find in any ventilator in the world. Nothing more, nothing less. I'll show you. You are seeing this? There are 3 graphs: pressure time graph, volume time graph, or flow time. None. Means this is pressure time scalar, volume time scalar, flow time scalar. Correct? Now, if I go to another part, where is that? I want to show you 2 loops. I don't know where it went, but there are only 2 loops. I missed that, but here, this is one graph. Means just want to show you that when you set a block, na, only these 3 scalars are there, and there are only 2 loops: flow volume and pressure volume. Volume remains common. Now we'll go to Google and let's see the different graphs. Ready? So pressure time scalar. Wonderful. Very, very important. So this is a pressure time scalar. I think it's coming quite nicely in it. You are able to see? Or we'll see. First we'll discuss. This is pressure time scalar. This is pressure time scale. Pressure on this axis, y-axis, and time always remains on the x-axis. So this is your pressure and this is your time. This is PIP, peak inspiratory pressure. Peak inspiratory pressure means total pressure allowed by the airway resistance and the compliance and elastance of the system. So this is peak air pressure. Somewhere it will be around 40 like this. Okay. So this is your peak expiratory pressure. Also it includes PEEP because that we have applied on the ventilator. So total peak inspiratory pressure means resistance plus compliance or your elastance plus PEEP. Combination of these three will give you a peak inspiratory pressure. How much airway resistance the system is providing, how much compliance or alveolar pressure of the system, and how much is the PEEP applied. So adding all three, what you call as peak inspiratory pressure on pressure time scalar. How will come to know the resistance of the system and alveolar pressure of the system? We'll discuss later on. First, we'll discuss the graphs. First is your, I think I need to show all 3 graphs on the simultaneous, 3 scalars on ventilator. Just let me know. 3 scalar graphs. like this. So I'll zoom it more. So these are the three graphs. The image is not clear, I think. Sorry. So these are the three graphs. One is your pressure time scaler, one is your volume time scaler, and the other is flow time scaler. Now you can see one thing common in these two. The pressure time scaler is always positive, the volume time graph is always positive, but your flow time graph is coming negative, showing negative in it. So this is how you identify these graphs. In any graph, any scalar in which one is time and one is flow, anything if it is going down in the system, it is your flow time scalar. Why? Because flow times from ventilator, the flow towards the patient is termed as positive, and from in expiration, the flow which is coming from the patient to the ventilator, the flow is termed as negative. So this is your positive flow which is towards the patient, and this is your expiratory phase, means the flow is reversed, it is negative from the patient to the ventilator, so it is a flow time scalar. This is volume, volume cannot be negative, so this is volume, and this is your pressure. More example on this. This is your pressure time scalar, this is your volume time scalar, and this is your this is negative, so it's a flow. Like this again. Sorry. This is your pressure, this is your volume, and this is your uh, flow. Now you have two loops. Two loops on ventilator. One is your, I think, ज़्यादा अच्छा था. This is your volume pressure, the pressure on this axis, volume on this axis. This is a pressure volume loop, and the other is flow volume loop. This is flow, and this is volume. Here the volume is on the y-axis, the volume is in the x-axis. But you need to understand the shape of this. We'll discuss all these graphs. So this is volume pressure, pressure on this axis, volume here. Here there is flow. This is inspiration, this is expiration, and this is volume. So these are the two loops, three scalars, and uh, uh, these are the five graphs on the ventilator. We'll discuss each and every graph. So right click on the image and open a new tab. Let me see if that screen it allows you to give a more better view. Oh yes, wow, thank you. Thank you, Dr. Sibeten. Not friendly with the net, but that's the way it is. Thank you for the tip. Now, what I was saying, out of this graph, you need why these graphs are important, because you know what is directly happening with the patient and how you can use this graph for the system. But before jumping into understand the first graph, which is pressure time graph, sorry, pressure time graph, uh, you need to understand one important concept regarding the flow and also the pressure in the system, and how we can switch on the go to the ventilatory controls. So whenever a ventilator is providing the breath, the flow is going from patient to the ventilator, and it is expanding the lung. So airway resistance is there, and there is a elastic pressure is there. Now, if during a breath we stop the flow, means your patient has inspired, a ventilator has delivered the breath, and we then halt the flow at this stage. There is no flow in the airway at this stage, so the resistance will become zero, and whatever the pressure remains is will remain as the alveolar pressure in the lung. Understood this? Again, ventilator is blowing into the patient like this, and at the end of inspiration we halt the inspiration and we stop this. Now at this stage there is no flow of air from into the airway, so there is no resistance is offering by the airway. The only pressure which the ventilator is now sensing is the pressure of the alveoli. That's why you, when you have peak inspiratory pressure, which we see on the pressure time scaler, it is the total pressure of the airway plus parenchyma and the PEEP. But you need to differentiate out of this total pressure what is the airway resistance pressure and what is the alveolar pressure, which is equivalent to compliance or elastance of the lung, how the parenchyma. So what you do on the ventilator, you click a button which is known as inspiratory pause. You put an inspiratory pause, that means at the end of inspiration there will be a pause on the ventilator and there will not be a flow inside the patient lung, patient airway. So the only pressure which will remain will be alveolar pressure. Now coming again back to our equation which we have understood, which we have seen so far. What was the equation? Anybody remember? Our pressure will be total airway pressure equal to resistance pressure. I hope everybody has noted down, equal plus elastance pressure. Resistance pressure was flow into resistance, at times sometimes call it Q also, plus elastance pressure. Now what I am telling you, at inspiration we pause the flow. At the end of inspiration we have stopped the flow. So this flow becomes zero. So this equation becomes 0 plus elastance pressure. Again I have told you we also call is alveolar pressure. So what the peak inspiratory pressure we'll see after inspiratory pause is only the elastic pressure, which is known as alveolar pressure. This is also termed as, somebody asked me, plateau pressure. Okay, so the alveolar pressure is equivalent to plateau pressure in simple terms. The pressure which the alveoli and the lung is providing to the ventilator is called your alveolar pressure. Resistance pressure we have, and how it is calculated on the ventilator, you put an inspiratory pause button and then your pressure time scaler graph will tell you what is the total inspiratory pressure and what is the alveolar pressure. That is how we go. Where is the button? Where is the button? Where is the button on the ventilator? Just I have taken a click. There are two buttons. One is inspiratory pause and expiratory pause. These two buttons come handy. This one, inspiratory button, comes handy to know what is your plateau pressure. Could you repeat, Ibrahim? Okay, we'll repeat. Okay, what I was telling Ibrahim, that when the ventilator is providing breath to the patient, the total pressure which the ventilator is facing is the resistance pressure plus the alveolar pressure. But we want to know if there is some pathology, in the lung, whether the problem is in the airway or whether the problem is in the parenchyma. We need to understand that. Okay. So how we'll do that? What we'll do is, during inspiration, we stop the flow for a second on the ventilator, 1 or 2 seconds, or 2 to 5 seconds. Now the flow in the airway becomes zero. There is no flow in the ventilator. So the pressure which the ventilator is now facing is only the alveolar pressure. How we come to know? This is the equation. The equation which I told you before was to sorry, total airway pressure equal to resistance pressure plus elastance pressure, or it could be resistance pressure plus, this is called alveolar pressure also, alveolar pressure So this resistance is equal to flow into resistance plus cellular pressure. Now, if flow becomes zero, if we pause the ventilator, we put an inspiratory pause on the ventilator. Now, this into our whatever the resistance, it becomes zero, and therefore it becomes LO pressure. So now this peak airway pressure is equivalent to LO pressure. So that's, and this LO pressure is known as plateau pressure. Why there is plateau? Because when we pause, when we give a inspiratory pause on the ventilator for 2-3 seconds, there comes a plateau. The pressure equalizes to a plateau, and that plateau, there is the term they get, it is plateau pressure. Now, how do you put an inspiratory pause on the ventilator? There are buttons on it, which I was saying you. These are the buttons: inspiratory pause button and the expiratory pause button. So when you give an inspiratory pause to the patient, there happens, you see, this is inspiration, and this is the pause. And at the end of the pause, where what the pressure remains is your plateau pressure. We'll see in the graph. So this is how you calculate the inspiratory pause. Expiratory pause. Expiratory pause is, we use it for calculating auto peak. We'll discuss in detail. First, let us see that pressure graph. You see, ना ये तो छोटा हो गया. So this is your pressure. This is your pressure time scaler. This is your peak pressure at the top. This peak pressure is equal to total airway pressure plus the peak. Now we suppose give a inspiratory pause at this stage. This pressure will drop, and the whatever the plateau pressure, whatever the pressure remains is your LO pressure. So this is how you know whether the problem is in the resistance of the system or whether the problem is in the compliance of the system. Let's see. Uh, एक second, just hold on. Pressure, time graph, troubleshooting. I am see. This is the graph. This is a pressure time scaler. This total peak inspiratory pressure means airway resistance pressure plus your alveolar pressure plus PEEP. PEEP you have set on the ventilator, so it is included in the plateau pressure. This is total plateau pressure. So ventilator will show you this peak inspiratory pressure. Then you apply the inspiratory pause. It will cause the flow to stop, so the flow becomes zero and the pressure will drop, and when it drops to a certain plateau, that is your alveolar pressure. So on ventilator graph, if your peak pressure is high, this inspiratory pause button will help you to understand whether there is a problem in your resistance of the system, means airway, or whether there is a problem in the compliance of the system or the lung parenchyma. Let's see the different etiologies. Oh, I got a beautiful graph on this. I hope it comes as a big. Uh, I don't know if I. So there are tremendous good amount of books are present there. Let's see this. This is a very good. How I move this around? Okay. Wonderful. So this is your normal pressure baseline. You will not see a plateau pressure regularly in your ventilator. What you will see is only your peak inspiratory pressure. This is your inspiration and this is your expiration. Inspiration, expiration. But they have put an inspiratory pause at the end of inspiration here, so that the flow becomes zero and the pressure drops to a plateau, which is your LO pressure. So this is normal. 4, 5 is the resistance pressure. Plateau pressure is somewhere 20-25. So peak inspiratory pressures total is normal is 15 to 20 somewhere. 15, 20, 22. This is your total peak airway pressure, which is normal. Out of this, 3, 4, 4, 5 is your resistance, and the remaining 10, 15, 20 is your 10, 15, or this is your plateau pressure. This is a normal thing. Now, what is happening? Your peak pressure is increased. Suppose on the ventilator alarm, ventilator, you are getting a something that your peak pressure is increased from 20 to now peak pressure is increased to 40. Now this peak pressure increase in 40, peak inspiratory pressure could be 40, the total pressure, it could be problem due to airway or it could be due to parenchyma. So what you will do, you will put an inspiratory pause button. That inspiratory pause button will make the flow zero during inspiration. So the only pressure will drop and the only pressure which will remain is alveolar pressure. Now by comparing you will see. Now here you can see the peak inspiratory pressure is there. You pause the inspiratory, put the inspiratory pause, the pressure drops and then it comes to a plateau and normal. Now comparing to this graph, you see the plateau pressure is normal. Pressure it is remains same. The problem is in the increased resistance of the system. So what could be the causes? The airway is creating the problem. So the problem could be patient is biting the tube, biting the tube. There could be a plug in the mucous membrane, plug in the endotracheal tube, or plug in the bronchioles of the system. Secretions inside the endotracheal tube. HMA filter get blocked. The filter which is remained there, it can get blocked. You have not changed the filter for 2-3 days and it get blocked. Then also what can happen, there is a foreign body into the airway systems or the endotracheal tube, somebody has changed from 8.5 to 7.5, now the airway pressure, or there is a bronchoconstriction. So all pathologies which causing an increase in the airway pressure, you need to understand. So inspiratory pause button helps to differentiate between whether the problem is in the respiratory airway mechanics or whether the problem is in the this system, plateau pressure. Now here in this graph also you are seeing the total peak airway pressure is increased. Barabar? The total peak airway pressure is increased. You put an inspiratory pause button. Now the resistance remain the same, this much, 4 or 5. But the plateau pressure is increased. So the problem is not with the airway right now. The problem is with the parenchyma, pleural effusion, pulmonary edema, pulmonary hemorrhage, atelectasis, pleural effusion, hemothorax, pneumothorax. All these in initial stage. These can give rise to your increase in the plateau pressures. So you get my point. So inspiratory pause button helps you to demonstrate how what is creating problem in the total peak inspiratory pressure. So you got my point? And thank you, Sibatin, for helping this right click and open image. I really like that. So the importance of pressure time scalar is uh, there is inspiration followed by expiration, inspiration and followed by expiration. So pressure time graph helps you to understand if the total increase in the airway pressure is due to airway resistance or airway compliance. How will where this peak pressures comes on the ventilator? To those who don't know, let's see. You are seeing this C peak, P peak pressures. This is the peak inspiratory pressure. Uh, Sorry, little bit. Mm. You see here 32 peak pressure 32. So understood. So this is where you see a peak pressure on your ventilator. Now we have given a, this is a test lung, this was a test lung, so we have shown you how to demonstrate this. peak pressures were rising, so we gave an inspiratory pause, and this plateau pressure is 20. So out of this 21, 20 is the plateau pressure, means remaining one is resistance. Peak pressure minus plateau one is the resistance. So the problem is in the parenchyma, not with the resistance of the system. So this is how pressure time scaler helps us to understand what is the problem. The graph which I have shown you, this graph which I've shown you, it comes very useful, becomes very useful for your exams also, and also very much clinically useful in your day-to-day practice. So pressure time scaler helps you to understand why the peak pressures are increasing, whether they are due to resistance of the system or whether they are due to the parenchymal disease of the system. So this point is clear, everyone? How to utilize the inspiratory pause and look for the pressure time scaler. Whenever you put an inspiratory pause, you have to look the pressure time scaler. Everybody understood this pressure time scaler and the utility of inspiratory pause, so that we can move forward. Next time we'll connect some people on Zoom also, so we can interact with them also. You can write in the chat box whether you understood this pressure time scaler, how to give inspiratory pause. Okay. I think I'm able to make you understand that. Okay. Thank you. Thank you. So I think it's understood. Yeah. So this is how you utilize the pressure time scaler. Secondly, now because we have discussed the inspiratory pause, at the same time we'll discuss the expiratory pause also. We have two buttons on the ventilator. One is inspiratory pause and one is expiratory pause. Now, for expiratory pause helps to detect autopsy. Okay, Rag Music have asked that inspiratory pause to apply it for how many seconds? Basically, on ventilator, it is tuned to 2 or 3 seconds. So if you even if you keep on applying the inspiratory pause, after 2 to 2 seconds, it will release. It will release by himself and it will give you the value. So usually 2 to 3 seconds we apply the pause, and even if you keep it applying, the ventilator will release it, and then it will give you the value of plateau pressure. This is how. Those who are listening, they will be get benefited, because next time when we'll try to have a video from the live ICU also on the ventilator. We can show you all these parameters. This will be pretty handy. Now coming to your expiratory pause. So what I was telling, that inspiratory pause helps you to make you understand what is the resistance pressure and what is the sorry, give me one second. What is the resistance and what is the LO pressure. But where expiratory pause comes handy? So I have shown you there are two buttons on the ventilator. One is inspiratory pause, expiratory. Expiratory pause helps to identify auto P. Many people have confusion in this. Many students have confusion. Many staff have confusion in this. But this is very important. Usually it comes handy in your COPD patients. You need to understand. We have seen on this that no, there was a graph. We have seen on this graph that your total airway pressure equal to resistance pressure, plateau pressure, and this from baseline 0 to 5, which we have said is your peak. Okay, but there is one intrinsic peak of the system. When a patient is not getting ventilated, uh, somebody is asking that we need a break for 2 minutes, but I think we'll after our expiratory pause we'll take a break for 2 minutes, but we will finish this auto peep things because we are in the middle of something very important. So uh, and to mind you, to all those who are listening, in the end we'll take 15 minutes and we'll compile what we have learned today. So there will 15-minute quick revision so that everybody can get to know what is happening. Okay. So auto peep means, I was telling the peep. In a normal scenario, your normal peep is maintained by a glottis. Okay. So if there is glottis is not there, normally glottis your vocal cords remain closed. So this provide a physiological peep so that the air which is in the alveoli doesn't get skipped. Okay, so this is a normal physio, or when you bypass the endotracheal tube here, there is the glottic pressure releases and you need to provide some beep to the patient, which is set on the ventilator. It is usually 4 5 3 to 5, which you set on the ventilator. Auto peak means there is some intrinsic peak which is getting developed in the ventilator. Usually it comes important in COPD patient. Now the pathology in the COPD patient is that the COPD patients are not able to exhale the air from their lungs. I'm keeping it a little slow so that you understand the auto peak. In normal patient, they can inspire and they can exhale very well. But in COPD patients, what is happening? They can inspire comfortably, but when they exhale, there is a severe bronchoconstriction. There is lot of wheeze. So the airway are narrower and they don't allow the air from the alveoli to get exhaled. So that that airway pressure, that airway narrowing creates an extra peep in the lung. It doesn't allow the air to get exhale. It doesn't allow the air to get exhale from the lung, and it keeps the alveoli open up. In the inspiration, the alveoli, suppose the alveoli is there and it get open, and then it stretches and then it tries to collapse to a normal value. But in this is the normal lung. It inhales, it expands and then it collapses. It expands and it collapses. But in COPD patient, where is the airway obstruction, they get expanded, but because of the airway pressure is there resistance, they are not able to get collapsed. They are not able to return to the normal value, and then you have another breath coming from the ventilator like this. And again, when they want to get collapsed, airway is not aligned, and they again get collapsed, and at one point of time they can rupture. So also in between the alveoli, there are capillaries going on, different capillaries going on, and those capillaries get crushed because of this expansion and airway pressure. So what happens? This auto peep creates hemodynamic instability. This auto peep makes the patient prone to barotrauma. So we need to identify, is there any intrinsic peep or auto peep getting inside the patient which is hampering the exhalation and which is disturbing the hemodynamics of the patient. So how you will get to know what is the auto peep? You need to give an expiratory pause, because when you give expiratory pause, uh, there will not be any flow during expiration, and then the pressure will equalize to which will be equal to your auto peep pressure. Again, that graph which I was that book which came across na? This is Chrome. So you see, this is your total pressure, this is inspiratory pressure, resistance pressure, this is a plateau pressure, and now they have created an expiratory phase. So this is your peep, this is here it is a 0, it will be a 0 peep which we have set 5, here somewhere around 4 or 5, and when you create an expiratory hold, this pressure starts to rise and it stabilizes up to a certain point. So this is your intrinsic peep plus 5. The below one is your set peep, and the total peep is set peep plus intrinsic peep is 10 mm CO2. Your target should be, intrinsic peep should be as minimal as possible, ideally 0. Again, you understood? Now you put an expiratory hold, there is no flow of air from during the expiration, and then this pressure will rise on the ventilator and it will come to a place where it will stabilize. So the pressure which is above your supplied peep is your intrinsic peep which the patient has, and this is your set peep. So the total peep will be 5. In exam it comes what is the intrinsic peep and what is the total peep. So don't get confused. Intrinsic peep is 5, extrinsic peep which you have given is 5, and total peep will be 7. Okay. So these are the things. So this is how you calculate the peep. If I can show you some extrinsic peep, look, let me check. Extrinsic peep on ventilator. You see, this is not clear. Let me get a clear image. Huh. You see, this is also a good graph. So this is, it's not very clear, but you will understand the point. In normal lung, there is a 0, the alveoli is open, and then when the inspiration is hold, means whenever there is expiration, it will come to a normal pressure and equalizes. Here the pressure becomes 0, it equalizes. It get during inspiration this alveoli get expanded to this size, and during expiration it comes back to its normal shape. So this is no airflow limitation at the end of expiration. But when there is a bronchoconstriction or something that is happening, what happens? There is a narrowing of the airway. So the alveoli get expanded, but it cannot get collapsed due to its normal shape, and that is an intrinsic peak which is in the system of the patient. See, this is the total pressure. At the end of expiration, they have applied a pressure, and then it's slow. This 5 is your normal peep, and at the this slowly rises and it comes to a certain level. So this extra peep which is there, it will give you a total peep value. The ventilator will not tell you. In new ventilator they have images, but the ventilator will tell you that the total peep is now this. From total peep you need to minus the peep which you are giving on the patient, so that will become an intrinsic peep. If the intrinsic peep, what are the consequences? If the intrinsic peep is high, this will cause the alveoli to collapse the capillaries in between different alveoli, and this will cause hemodynamic instability, and also the alveoli can rupture. I'll show you on my iPad. This is important actually. This is important because until unless you understand this, the importance of peep is very important. Suppose, sorry, I have not, I have mentioned IPEEP. Suppose these are your different alveoli, है ना? Different alveoli, है ना? Now we can expand this. Expand this. One alveoli, two alveoli, three alveoli, and your blood vessels are going in between the alveoli, like this. Now what? When this alveoli open up, like this, like this. What will happen? It will compress on the capillaries because a single endothelium capillaries are there. Now, when they open up and then they collapse, open up. But in intrinsic PEEP is too much there. They will open up to extend. They will open up to extend that they will compress the capillaries. So when they will compress the capillaries, there will not be a forward flow, and then the blood pressure starts dropping very fast. Secondly, these alveoli can rupture and that can create barotrauma. So if there is an extensive, very much extrinsic PEEP, the alveoli can compress the capillaries and there can be hemodynamic instability. That's why it is very common in COPD patients. If you have given, it's very common in COPD patient when you ventilate a patient and suppose your ventilator settings are not good, and you what you have done is you have kept a PEEP a little high. The patient's ventilatory patient hemodynamics BP falls down drastically. It was 140 before the start of intubation. It comes to 70. You are wondering, I have not given too much sedation, I have not given fluid, still the patient's BP is not waking up. Before ventilation is what good, and now the ventilation after ventilation it is not picking up. So that means there is an extensive intrinsic PEEP, and because of the auto PEEP or intrinsic PEEP, the capillaries get collapsed, crushed in between the alveoli, and the BP has fallen. What to do? Just disconnect the ventilator for a few seconds, 30, 40, 30, somewhere around 10-15 seconds, and you will see the BP start rising again. So whenever you ventilate a COPD patient and you have a drastic fall on the BP just after ventilation, think of there is extensive auto PEEP because of this. How you can check that? I told you there is. You see, there are there is expiratory pause button and there is an inspiratory pause button. And in both the things, in both the things, in both the things, you need to see the pressure time scaler. So so everyone had understood that intrinsic PEEP for inspiratory pause will tell you whether the resistance is increasing or the compliance of the system is a problem. What is the peak pressure after total peak pressure? What is your resistance pressure and what is your plateau pressure? Extrinsic PEEP or auto PEEP is determined by your expiratory pause maneuver. You put an expiratory pause, and at the end of expiration, there will hold, and the P low baseline value of plateau pressure graph will come to rise to a certain level. That is the total P, out of which you minus the P which is ventilator is providing 5, 4, 3, जो भी है, and then that is your auto P. Try to keep auto P as low as possible. You understood the auto PEEP significance? Two consequences. It can cause hemodynamic instability because it will crush the capillaries in between the alveoli, and secondly, the alveoli can rupture and it called pneumothorax. So that's the significance of auto PEEP, and it is identified by giving expiratory pause on the ventilatory circuit. If you have understood this, write in the chat box, and then we'll have a 2-minute break as asked, because we need to understand other graphs also. It's 12:35 in Indian Standard Time, and in next 60 to 90 minutes we'll cover up this live stream, in which we'll cover different graphs also, and then we'll as well as do the troubleshooting also on the ventilator. We'll finish it because now the things will not be very much difficult once you have understood this, but you need to understand few graphs and loops. How to deal with auto PEEP? Yes, Ibrahim, this is a good question. For auto PEEP to handle, first you need to remove the cause, like if there is severe bronchoconstriction, give bronchodilators. You can decrease the PEEP on the ventilator. You can give less tidal volume so that the less pressure is generated. That is the thing. But if the patient is on spontaneous mode ventilation or NIV, Then you need to give some extra P to overcome the airway resistance. That is a different story we'll discuss in the troubleshoot settings. But for right now, the immediate thing is disconnect the ventilator, see if it is because of autopeep, or if the patient has ventilator, get an expiratory pause, look for the autopeep, give bronchodilators, decrease the tidal volume, increase the expiratory rate, let the inspiratory expiratory ratio make it 1 is to 4, 1 is to 5, let the expiratory phase be longer so that the air lung can exhale. These are the maneuvers which you need to do. So if we people have understood, let's have a 2 minute break. I also need it so that we can understand other graphs and things, and then we'll cover the troubleshooting and other parts also within next 60 to 90 minutes. You can have your tea, ask someone to bring tea, have your water, anything. So 2 to 3 minutes break we are taking. Then 2 minutes break. Thank you. Okay. If you all have come back, we can start the flow time scalar graph now. Just a second. Let me find a good flow time scalar. Okay. Everybody has come. So we'll start. I'm just finding a good graph to you. Sorry. Uh, okay. Yes. Okay. So now, welcome back. So thank you for connecting with us. And in next 60 or 70 minutes, we'll finish up the session. And then in this session, will remaining graphs and the troubleshooting will cover. And then sooner somebody has posted on the session that we should be repeated, this session should be repeated in a week or month. Obviously we'll repeat it with some more graphs, with some more concept, but in this session, to selected candidates, because there is a limit on the Zoom, we'll provide Zoom link to some 60-70 students so that we can interact with them live. Also, I will try to make short videos on the ventilator in a playlist so that every concept is explained in detail. But for the sake of time, wanted to explain you all the things in one go so that you need to understand how these are because how these are important, how there is a connectivity maintained in across all the things which we are discussing. Okay, so now we are starting again. We have discussed the pressure time scalar. Now the utility comes for flow time scalar. How will you identify the flow time graph on the ventilator? The flow towards the patient will be positive and away from the patient is negative. So the only so what will happen? The only graph which will have a negative flow, negative deflection on the ventilator is your flow time graph. Let's see. This is your inspiration. Here the patient has triggered the inspiration or whatever the inspiration is given. Then inspiration ends, expiration start, and now the flow is from the patient to the ventilator. That's why it is expiration. This is inspiration on the ventilator, and this is expiration on the ventilator. Inspiration always positive, expiration always negative. So patient is given a flow to the patient is positive, and now the flow is coming from the ventilator to the patient is This is negative deflection. So the inspiration is positive, expiration is negative. Now this can be square and this can be deaccelerated type. On the ventilator you can adjust the type of flow in two types. One is square wave pattern and another is deaccelerating type of pattern. So we should have a discussion on this. Now you have seen two things. The flow can be square wave pattern and the flow can be deaccelerated type of pattern. On the ventilator also, uh, there is a column for that to set. Let me show you. So that then we'll discuss why it is important. I wanted to show you so many things that you can see. This is your deaccelerating type of pattern and this is your square pattern. This is deaccelerating type of pattern which you can set and this is square pattern which you can set. So that's what I was telling you. This is a square wave pattern of the flow form. This is a deaccelerated form of pattern form. What is the difference? What is the difference in these two? So understand, there are two modes of control modes of ventilation. One is your volume control mode and the other one is pressure control mode. So in volume control mode, we have decided that this amount of volume will go with this much flow towards the patient. So the variable which will vary is your pressure. Suppose I have decided that 450 ml of volume will go to the patient and then it will go up with a rate of 45 ml per liter. And this flow will go till 450 ml of tidal volume is achieved. This is I have set on volume control mode. On pressure control mode, I have told the ventilator that with this pressure for this second, give the breath, whatever amount of tidal volume will generate, they will depend on the patient. So I will tell the pressure that the pressure in the airway should be around 30, should be around 20 and you should give for this much time. So it will be same. So only the pressure can be set on the pressure control mode. So, but in volume control mode, I have fixed the flow that with this amount of tidal volume for this amount of flow should be delivered. Pressure may vary. If it is a if it is a bronchoconstriction, then also my ventilator will try to put 450 or 500 ml of volume till his tidal volume is achieved. If it is a dilated tube also, then also it will provide 450 or 500 ml of volume to the patient. So that flow is fixed and volume is fixed in volume control mode. So the type of flow you are deciding only on volume control mode. So whether it will be delivered in a square pattern or whether it will be delivered in a deaccelerating type of pattern will be only be able to set in volume control mode. The square or deaccelerating pattern is not able, you are not able to set on pressure control mode or pressure support mode. Only thing you will be able to set in volume control mode. This is important. In your ventilator, if you are not able to find the square wave pattern or deaccelerated pattern option, that means you are not in volume control mode, you are in some different mode of ventilator. So now, what is the importance of this square wave pattern or deaccelerated forward? You have an alveoli, suppose you have an alveoli in the lung and you are blowing it from the top. So suppose alveoli is at zero pressure and you started having this blowing from the top of the ventilator. So the alveoli will also get expanded, it will generate a pressure. So when you inspire, the pressure which you generate in the start is not the same at the end of inspiration. The pressure decreases throughout the breath. You try it. So the pressure, the flow remains high. The flow remains high at the inspiration. It gradually falls towards the end of inspiration because in the initial stage the alveoli is at zero pressure. You are blowing at full pressure and now the alveoli also started having pressure to it resists. So the flow is in a decelerating pattern like this. So that's why it is a decelerating pattern. This is a decelerating pattern. But I want, no, this flow should remain constant throughout the inspiration. Whatever happens to the pressure, I'm not bothered. So the pressure, the flow will be, so flow has not decreased. At the cost of increase in the alveolar pressure, the flow has remained constant throughout the breath. So what are the advantages? Because the flow is constant, there will be more oxygenation, more chances of patient getting properly oxygenated will be there. But what will happen? The pressure in the airway will remain high. The alveoli will receive high pressure, and there is chance of barotrauma. So whenever you have a square wave pattern on volume control mode for flow, constant flow throughout the inspiration, your peak pressures will increase. It is not physiological. While de-accelerating pattern is flow is highest in the maximum, and as the inspiration progresses, it slows down, de-accelerates. It's physiological. It's more physiological. So peak pressures will be at a lower level when you choose the de-accelerating pattern. In our patient, most of the time it's by default de-accelerating pattern, and worldwide also most of the ventilator they choose a de-accelerating. When this patient is set on constant flow pattern, the oxygenation can improve because the flow is throughout the same for the respiratory cycle, but inspiratory pressure will be high. We use in refractory ARDS when the oxygenation is so important that whatever the cause, we need to oxygenate this patient. So in those on those we can try square wave pattern, but for all default, for every default setting, it is always de-accelerating pattern. So uh, so this is the thing. This is a more physiological approach. Flow is high at the start of inspiration, and as the inspiration progresses, the flow decreases and matches with the alveoli at the end. This is a square pattern. Square pattern, what will happen? You see the peak pressures are high in the starting and it is physiological. But here, this is a square pattern. The flow remains constant throughout the inspiration and it causes very high peak pressures. So it is not physiological. This is only available in the volume control mode because you can adjust the type of flow in the volume control only. Pressure is variable. In pressure support or pressure control mode, because pressure needs to be constant, it cannot go high to a certain limit. So flow has to be the accelerating pattern. If it is not, if pressure in pressure control mode, we have said that pressure should not go up to a certain limit, beyond a certain height. So it has to be the accelerating pattern. So this is your square wave pattern or de-accelerating form of pattern, which is there on volume control mode to decide the type of flow. Normally 99% this is more physiological. It is physiological. This is not physiological. We use this de-accelerating pattern in all our patients except for some ARDS patient as a last resort. Square wave pattern, we don't use it, but the benefit is it can little more increase the oxygenation, but at the cost of increasing the peak airway pressure. So I think so. This is now again coming to your graph. In your flow time graph, this is your inspiration and this is your expiration. Okay, this square wave pattern or this you can set on the ventilator. Now the benefit of this graph is it can tell you whether your expiratory phase is complete or incomplete. Again, coming back to my live scene. Somebody has asked me in the previous comment that how will you set the inspiratory expiratory ratio of the patient, and how you will adjust, how will minimize the auto peak. These two questions were asked by some other doctors or some members on the channel. So this flow time scaler will help you. What? How you will adjust your inspiratory expiratory ratio and how you will decrease the auto peak. So, somebody has given me dislike on this. I don't know which point they are not able to understand. 171 likes, but one there is a dislike. Those who the person who has given dislike can ask their question what they haven't understood. Anyway, so or what we have not understood. So now flow time scaler comes in handy when you want to be more focused on your expiratory phase. So what will happen? Will first there is inspiration, this inspiration, and then will be a exhalation flow toward from the patient towards the ventilator. It should it should the expiration phase should be complete. The expiration phase should touch the baseline. That means your expiratory phase is complete. Like in this, you are seeing this. This expiratory phase should touch the baseline. If it is not touching the baseline, that means your expiratory phase is not incomplete. That means you need to increase the expiratory phase. That means the patient is at risk of autopsy. Let's see. Uh, there are two graphs. Yeah, you are seeing this. This is a square wave pattern in which this is the inspiration, this is the expiration. The expiration should go there and it should touch the baseline. So that means expiratory phase is complete. But what is happening? Inspiration is good, but expiration is taking time. It's taking time, and without touching the baseline, this touching the inspiration has started again. So what does this mean? This means we haven't allowed the expiratory phase to complete, and because we haven't allowed the expiratory phase to complete, there will be retention of PCO2, there will be autopsy, and there will be a PCO2 will go high in the patient. So flow time scaler is very helpful in picking up your autopsy and adjusting your IO ratio. So you should target that as far as possible this expiratory phase should touch the baseline. You understood? Like this here also. Here this was the inspiratory phase, this was the expiratory phase, and this has touched the baseline. This is the inspiratory phase, this is the expiratory phase, it touched the baseline. Now what is happening here? It is inspiration and this expiration is prolonging. Obviously it is prolonged because there is some obstruction in the airway, but it is not touched the baseline and again the inspiration is started. That's why this means the expiration phase is not complete. You need to increase I ratio. You need to give expiration more time, or you need to take maneuvers for bronchodilation, and you need to adjust the setting because this patient is at risk of autopsy. So this was the biggest advantage of flow time scaler, is you can focus on this focus on the expiratory phase also. Okay, so how to increase or decrease the I ratio? I ratio is being adjusted on the ventilator via flow parameter. Let me show you. Here is it. You see, this is the flow. So when you see, this is the flow. When you adjust the flow, I think it is not mentioning, but when you start adjusting the flow, if you give more flow, if you increase the flow to the patient, the breath will be delivered fast. So your inspiratory time will be short and expiratory time will be fast. When you decrease the flow will take time during inspiration to reach its target value, and then expiratory time will be slow. So you can adjust the flow, it will adjust the inspiratory expiratory ratio, and at the top of there you will find the inspiratory expiratory ratio. So you can adjust the flow on ventilator and it will help you adjusting the inspiratory expiratory phase of the patient. So the value of flow time graph, how to identify the flow time graph? That it is the only graph on the ventilator which has a negative deflection. Secondly, it helps you to keep focus on the expiratory phase so that you can adjust the expiratory timing, how, whether the patient is developing autopsy, whether the patient is having gas trapping, whether we need to increase the I ratio. So this is the beauty of flow time graph. Flow time graph can be square shaped, flow time graph can be de-accelerating type. De-accelerating type is a more physiological, which we use in most of the patient. Square type is not physiological, but it helps to increase the oxygenation of the patient at the cost of peak airway pressure. So this is flow time graph. Now, have you understood the flow time graph? Then we can move to volume time graph. It is very simple. Volume time graph is nothing more. It's one of the easiest graph to understand. Okay, and then I will show you the trick to how to identify between the pressure and volume graph. Okay, so now Dr. Siddiqui here, sir, effect of bronchodilator or expiratory part of the graph. It's very easy. When you give bronchodilators, the airway gets dilated and the expiration is fast enough because there is more space for air to escape. So it will not increase the expiratory ratio, but what will have in that limited amount of time, now you have more space for the air to escape the lung, so the expiration will get completed during that period. So bronchodilator helps in getting the air exhale properly. Now we'll switch to uh, volume graph. Volume graph is one of the simplest graph you have. What you can pick from the volume graph is, I'll tell you, volume cannot be negative. You give the patient to the, you give certain volume to the patient, you volume gets exhaled. Volume cannot be negative. So this is a volume, 450 tidal volume, it goes there and it goes exhale. If it is goes there and exhale, it goes there and exhale. So this is your volume graph. From volume graph, what you can pick is leaks. If your volume graph is going positive, blood gas is getting exhaled and suddenly there is a drip, it doesn't touches the baseline and it comes drastically shorter, that means at the end of expiration some gas has exhaled very fast from somewhere into the circuit. That is because of certain leak which is going on to the uh, mm, patient. Let me show you by drawing it. Suppose this is your volume. Volume goes up and volume goes down. Now what happens? Your volume goes up, your volume goes down, and it cut offs. It drastically comes to zero. That means your air has escaped from somewhere. That means there is a leak in the circuit. Right? So you need to find the leaks in the circuit, or for this you need to find leak. What is happening with the circuit? So what will happen? The tidal volume on the ventilator on the exhalatory port will not show completely. Volume should come up and it should get completed. Volume should go up and it could get completed. If it is not touching the baseline, that means there is some leak in the circuit. You need to find out. You got my point? Volume graph is very easy. It is a very easy. You just have a positive graph upwards, touches the certain tidal volume and it get exhaled. If it is not getting exhaled properly, it is cut off at a certain level. It comes drastically. That means there is a leak in the circuit. So that's the only importance of volume graph. The most advantages. What is the most advantage? Most two graph which I choose on the ventilator is your pressure time scalar and your flow time scalar. These are the graph. Now, how to identify? You have identified flow time scalar. This is the only graph which is a negative deflection on the ventilator. How to understand the difference between the pressure time scalar and volume time scalar, because both are positive. So here is the trick. Usually, if let me see if this image can have. See, this is this is your pressure time scalar, this is your flow time scalar because it's a negative deflection, and this is a volume time scalar. Now you see here, one obviously if you can see the readings, it is 0, 10, 20, 30, 40, the pressure scale is there, and here it will be a liter, volume will be written 200 ml, 400 ml, 600 ml, like this you can add. Secondly, when you applied the PEEP on the ventilator, there is some portion which will be above the baseline. You have applied a baseline value of 5. So it will always remain above the 5. While in volume it starts from 0. 0 to 450, then comes to baseline. 0 to this, and this comes to baseline. So this is how you can identify two things. One, on this graph, it will not start from the baseline because rarely you will keep the patient PEEP 0. It will somewhere 3, 4, 5. So it will start above baseline. It will start from the baseline. Okay. So this is how you can pick, and here if the scales are given, it will be centimeter of water because this is a pressure, and here it will be liter because you are discussing about the volume of the patient. And the graph which is negative in the deflection is uh, your flow time curve. So this is about the three graphs. uh, now we'll switch to two loops. What were the loops? Pressure volume loop and flow volume loops. And once we have covered the graphs, we'll come to troubleshooting on the ventilator in different jurisdiction. What are the problem in different ventilator? We'll finish that in 30 minutes. So next 10 to 15 minutes about the two loops, volume and pressure loops, and second will be pressure volume loop. I hope everybody is alert and not getting bored. If you are feeling that it is getting too long, I need to stop, do let me know. But I am trying that after graphs, some 30-40 minutes of troubleshooting I should finish, so that in one session you have broad idea about all the aspects of the ventilator. Okay. Now we have only two loops on ventilator. The two loops on the ventilator is now the second loop, first loop is your volume pressure. This is the volume, this is the pressure. Two variables, no time. Very simple, very simple. You are blowing air into the lung, and as the pressure is increasing, the volume will expand. You are providing certain positive airway pressure to the patient's lung, and the lung is expanding. That's what this graph is telling. On this scale, there is a pressure, and on this scale, on the y-axis, there is a volume. So you are from here, the pressure is 0, and then you start providing pressure. The pressure ventilator, what is happening? The volume start increasing the lung, and then up to at a certain point, the lung expand fully. So this is at this pressure, the lung involves, it reaches to a tidal volume 450, and then it exhales. So the pressure you applied, the lung expands and the lung closes. The pressure you applied, the lung expands and that closes. This is what this tells you. Then the only thing. Now suppose the lung is stiff. This what is the utility of volume pressure curve, volume pressure loop? By volume pressure loop, you can dynamically, you can see whether my lung is improving in terms of compliance or decreasing in terms of compliance, deteriorating in terms of compliance. Suppose, uh, let me show you by iPad. Now what is happening? This is your pressure, this is your volume. You start applying certain pressure, and now the lung expanded. So now the lung expanded and now the lung exhaled. This is inspiration, this is expiration. Barabar? Okay. Now what happens? Same graph, but what is happening? Now this is a that type of balloon which you have kept for 1 year and now trying to expand. Now you are, this is pressure, this is volume. Now you are applying a lot of pressure, lot of pressure. Still the lung is not expanding. Now start expanding and then it gets close. So you are seeing the graph, the loop is tilted or came down to x-axis. It was somewhere around the 45 degree, and now what is happening? You keep on applying pressure, but the lung tidal volume is not expanding. But after a certain point, it expands and comes back. So you are applying more pressure, you are requiring more pressure to expand the lung, and the graph has tilted toward the x-axis. So if you on ventilator see a graph, the volume pressure graph, and it is coming down toward the x-axis, that means the compliance of the lung is decreasing. The lung is becoming stiff. Understood? Now the same patient, sorry, same patient, same patient. You applied a little pressure, the lung expanded, and then it come back. Okay, the lung expanded. So this is pressure, this is volume. You applied a little pressure and expanded. So that means lung is very stretchable. You applied a little pressure and the lung expands. So the graph is tilted, it has become straightened. So if you on your volume pressure loop, this is 45 degree. If it is getting down towards the x-axis, that means the compliance of the lung is decreasing because you need more pressure to apply and then expand the lung. Same volume pressure graph, if this tilts toward it becomes more straightened. That means you apply little pressure, it tidal volume increases. So if your graph is increasing, coming towards the y-axis, that means the compliance of the lung is increasing. So this is the utility of your volume pressure curve. I had captured one thing here. I think, let me see if I have captured a loop. One loop is was there क्या? I'm not able to capture that loop. This is something different. Okay, so you understood this point? You understood the significance of volume pressure loop? Write me in the chat box. By pressure volume loop, you volume pressure loop, you can understand the compliance. You said you see on the ventilator there is a compliance, there is a volume pressure loop. If it is 45 degree, normal compliance. If it is flattening, that means you require more pressure and then the lung expand. That means that your pressure lung is getting less compliant. If you apply little pressure and the lung expand and the loop is coming more towards the y-axis, it is straighten up. That means your lung is more compliant. Same patient. Yes, very nice question with Shrikant. In fibrosis, the compliance of the lung is less, very less, because the lung is not stretchable. So the graph will be a flatter curve. Now you suppose in ARDS, the compliance has decreased, and now you are giving the therapy, and you see on the next 2-3 days that this volume pressure curve from here to start coming like this, getting straightened. That means your lung is becoming improved, the compliance is improving in the lung. So you don't need to remember the values per se, on the ventilator. The beauty of graphs, ventilator graph, is you don't need to remember the value. You just see what is happening in the patient and you can understand. So the graph which was like this and now straightening up like this, that means the compliance is getting improved. With same amount of pressure, the lung is getting more expanded. So this is the value of uh, volume pressure loop. It is very, very, very nice. The trend of this graph should be monitored. So if you all understood, we can move to last loop, which is volume flow loop. Volume flow loop. Okay. Let me find a good volume flow loop for you. I haven't prepared on the PPT just because I wanted to show you certain facts. Okay. Sorry. Okay. So now the last loop on the ventilator is your volume and flow loop. This is your flow and this is your volume. Again, an x-axis here it is volume and this is your flow. This is your inspiration and this is your expiration. This loop helps you to identify leak or gas trapping. Very simple. Or bronchoconstriction. This is a normal inspiration and this is a expiration. Now if this expiratory loop is not, if expiratory loop is not getting closed, that means there is a air trapping. Expiratory rate is not allowed to close. If this this is air trapping, you see, this is air trapping. Now if there is a scoop in the loop, scooping of like this, if this is your normal, you see this is inspiration, this is exhalation, this is normal, it gets completed. But if it is not able to complete and touch the zero mark here, that means there is air trapping. Other than there is a scoop, if it get like this, it gets a scoop. This is scoop, it is not able to cover its routine path. That means there is a scoop in the loop, that means there is a severe bronchoconstriction, the flow has become turbulent, or there is a too much fluid or oscillations, condensation in the tube. So you need to see this if it is there is scoop in the loop. So it is helpful in the spirometry, but I don't use this graph too much on the ventilator. But you need to understand, if the expiratory phase is not getting completed, that means there is air trapping. Or if there is bronchoconstriction, what will happen, the air will not escape smoothly, it will face the resistance. So there is a scoop in the loop, this scoop in the loop, scoop in the expiratory phase. So that's the only value of volume flow loop or flow volume loop. I don't use it very uh, much in the clinical practice, means routine. But if I had to say three things on the ventilator, I will say it is pressure time scaler, flow time scaler, and your flow volume loop. Sorry, pressure volume loop. These are the three things which are I will have. So this completes your graph basics. Every see what is happening, every session on ventilator, like whether the modes or graphs or troubleshooting, I can take a lecture on full day for any of them. But to cover all those three things in one session of 3-4 hours, we need to stick to the basics so that everybody understand the concepts behind it, so that we can build up on this and take a separate section on all those three. So that's the way. If everybody is comfortable with all these graphs and scalars, loops, we can now jump to troubleshooting. Aarti has asked one important question. What is driving pressure is important. So this is for someone. Uh, See, basically in ARDS, driving pressure comes in ARDS. How I can explain that in hemodynamics you have a systolic blood pressure, you have a diastolic blood pressure, but in critical care what we say that we are more interested in mean arterial pressure, so map is more important. So that's why in ARDS they try to find out what is the single most parameter which is very very important, which tells whether the lungs are recruitable or whether we are damaging the lung, or what are the parameters due to which whether the um, PEEP or plateau pressures are damaging the lung. So in ARDS, what are the targets? You can increase the PEEP on the ventilator so to manage the oxygenation, but on plateau pressure should be less than 30, because if alveolar pressure is very high, there is a chance of getting alveoli damage or rupture is very high. But plateau pressure was also not very much useful in predicting the damage to the lung or ventilator associated lung injury. So what they come up with a parameter which is known as driving pressure, and driving pressure is nothing, which I'll tell you is very simple terms. Driving pressure is nothing but plateau pressure minus P. You give a inspiratory pause on pressure time scalar, and when you get a plateau pressure minus P for that patient, and this pressure which you get, the pressure which is keeping the alveoli open and expanded, it is called driving pressure, and it should be less than 14. Some say it's 13, but it should be less than 14. If your driving pressure is high, driving pressure high means the pressure which is keeping the lung alveoli is very high, and it will can cause barotrauma, biotrauma, all those things. So the on pressure time scalar, you get an inspiratory pause, see the plateau pressure and minus the PEEP from it, and that you will get the driving pressure. So driving pressure is nothing but a simple term, but it is very very useful. It is more sensitive for providing you the data that whether your ventilator setting is fine enough, your lung is fine enough. If the driving pressure is more than 40, more than 14, 15, 16, 18, 20, that means the lung are at the risk of barotrauma and biotrauma. It can rupture. So it should be uh, um, um, less than 14. Now we have completed this plateau pressure. Okay, so one more thing, one very a good question. What is the difference between NIV mode, pressure support mode, and BiPAP mode? So all are same, like this. Understand? I have made a video also on this, but you need to understand when we provide CPAP, means continuous airway pressure. This is not an IV mode lecture, but because the question is very good, so I am covering in 1 minute. When you provide CPAP, means a continuous pressure to the patient. So whether patient is inspiring or expiring, a constant pressure is present throughout the respiratory cycle. So whether inspire or expire, a constant pressure is provided toward the um, whole cycle. But when you switch to BiPAP mode, what we provide is that constant pressure is keeping the alveoli open, because we don't want the alveoli to get collapsed. But during inspiration, we provide extra support to the patient so that the lung can get expand fully. So that is inspiratory pressure IPAP, and that is and the constant pressure which you are providing throughout the cycle is your EPAP. So EPAP is basically preventing your alveoli to get collapsed, and IPAP helps you to inhale more air, helps the patient to inhale more air, and it helps to ventilate the patient. So if you switch these two, means EPAP and IPAP, you switch to ventilator, Your PEEP is your EPAP. This PEEP is present throughout the respiratory cycle and it prevents the alveoli to collapse. This is your EPAP. And the pressure support which you provide 10, 5, 12, whatever is your IPAP. This helps the patient to breathe the air, inhale more air. So this is so your pressure support above PEEP is same, your NIV is same, your BiPAP is same. Your EPAP is PEEP, and your IPAP is the pressure support which you have provided. That's the thing. We have a video on this. We can go in the channel and discuss. So now we have understood the graphs and the scalar, and now what we want is we'll go to switching, uh, troubleshooting on the ventilator. Just a second. Give me a second. है ना? Just give me a second. If you have any question right now till the session, you can ask. है ना? Just you can write down in the comment section. Okay. You can write down any comments on the section so that we'll start the troubleshooting. Now, what can go wrong? Now, when you are providing, sorry. So, troubleshooting. After this 15-20 minutes of troubleshooting, we'll switch to a quick revision and take the other questions, and we'll finish up by 2:10 or 2:15. Okay. So, we know we from the in the starting we told that ventilator needs three things. One, trigger, that what is the thing by which the ventilator can initiate a breath on the ventilator. Second is how the breath will be delivered. Will be a pressure control more or volume control, and it's a target. And then the cycle. Cycle means when the patient will ventilator will terminate the inspiratory phase. So that's the way troubleshooting can help. So we call as patient ventilator asynchrony or patient ventilator desynchrony. So desynchrony can be either the trigger is not appropriate or the target which is the ventilator which is delivering the thing is not appropriate, or the cycle it is not terminating at the inspiration timely. That's the only thing which can happen on a ventilator. Okay, so trigger, early trigger or late trigger. Okay, trigger, early trigger also. Patient ventilator synchrony, if we think of trigger, means patient is triggering but ventilator is not providing the breath. So we call this ineffective trigger. Ineffective trigger, when the ineffective trigger can happen, if you have the sensitivity of the trigger which you have kept is very high. Suppose it is normal is -3 ml per liter. So patient has to trigger like this, and then the ventilator will give. Suppose somebody has switched it to 10 liter, but 8 liter on the ventilator setting. So now the patient has to provide. Patient has to develop this much effort, and then only the ventilator can trigger a breath. So usually it doesn't happen. So trigger we usually forget, but you need to always see on the ventilator what is the trigger. It's somewhere around -3. It should be there. So ineffective trigger. Ineffective trigger can also be when patient is not developing good amount of effort. You need at least minus 3 ml of what you have set on the ventilator like this, and you need to then the ventilator can sense the breath and give. But if the patient is taking breath like this, means it is not generating enough negative flow by which the ventilator can give. How this will look on the ventilator? Let's see how this ineffective trigger can look in the ineffective breath, ineffective trigger on ventilator. Yeah, you see, this is a pressure time scaler, this is a flow time scaler, and this is a volume. Volume is starting from the baseline, pressure is starting about the baseline, and the flow is having negative. Now you see that there is a dip. Whenever there is a dip in the pressure, means there is a negative pressure and the ventilator patient has triggered the breath. But this trigger is not followed by a normal breath. That means this is ineffective. On the pressure time scaler, if you find a negative deflection and negative reflections are not followed by a normal breath, that means this is ineffective trigger. You need to adjust your ventilator setting. You need to provide either decrease the sensitivity of the trigger or help the patient, or patient is at this present not in a state to get wean, and this is why this is called an ineffective trigger. So get my point? Ineffective trigger means patient is developed some breath, but it is not able to generate, not able to trigger the breath. So patient ventilator asynchrony we divided into three components: problem with the trigger, problem with the target, how the breath is developed, and problem with the cycle. So in trigger, the most common problem is ineffective trigger. Patient is not able to generate the breath. So how will you find it? On the pressure time scaler, you have negative deflection which is not followed by a complete breath. Then there can be double triggering, more triggering. How this can happen? If there is a water in the excessive condensation in the respiratory circuit, or the sensitivity is very low, you have set to minus 1 ml per liter on the ventilator, then in even if the smallest breath can trigger the breath of the patient. So that's the way it can be picked, and there will be multiple breaths. Sometimes as cardiac oscillation, patient is having tachycardia, or patient has a dynamic palpitations, then it can also move the patient. It can also hamper the circle. It can also make the patient sense there are oscillation in the ventilator circuit, and then it can trigger the breath. So ineffective trigger or double triggering, excessive triggering, these are the problem. Now cycle means the ventilator is not completing the cycle properly. Two things can happen: early cycling and late cycling. Early cycling means patient wants the breath, still wants the breath, but before the breath is completed, the patient ventilator has cycled off the inspiration. So how will you get this on the ventilator? On the ventilator, what will happen? The pressure will fall. Uh, Let me show you. Early cycling on ventilator. It's a tricky one, but you need to let me zoom it more. Just a second. If I can see if I can open it in a new tab. Okay. So you see, this is early cycle and this is late cycle. This is your early cycle means patients wants to take breath, but ventilator has cut off the ended of the inspiration. So this was a pressure which was going on, going on, and now what happened? Ventilator has ended the inspiration here only. So there is a dip because patient is still inhaling the breath, but the ventilator is cut off. So what happened? The diaphragm is pulled down. It will make the it has make the pressure fall. So you can see there is in the pressure the time scaler there is a dip in the there is a deep dip in the graph. This is early cycling. Late cycling means patient has doesn't want the inspiration, wants to an inspiration, but is still ventilator still keep on trying the giving the breath. So what will happen? There is a steeping at the end. Patient wants to end the breath here, but the ventilator keeps on giving the breath. So the at the end of the pressure airway, there is a peak. There will be peaking appearance. There is a peaking appearance at the end of the inspiration. At the end of the inspiration, this is beaking appearance, which is called late cycle, and there is a dip in the ventilator. It will cause early cycling. So this was about cycling. And one more thing which you need to understand during that flow, during the target flow, is your and during the target flow in between the is air hunger. Air hunger basically you need a flow hunger. What you call is flow hunger on ventilator means it is represented by a dip in the uh, sorry. So you see now what is happening on the ventilator on volume control mode ventilation. You have fixed the volume and fixed the flow. So the flow cannot change, the volume cannot change. But 450 tidal volume may not be inappropriate, may not be appropriate for a obese patient or for somebody who is an athlete or somebody who is having COPD. They need 500 ml, but you have said 450. So 450 is not good for every patient. So what they want is there a hunger of flow, there is a hunger of volume. So because on ventilator in the volume control mode, you have fixed the flow, so the flow cannot change, the volume cannot change, but the pressure will fall because the patient will inspire and they need more extra flow. So what will you see is they will not see any change in the flow graph. You will see a dip in the pressure because you will suck the air, patient will try to suck the air and there will decrease in the pressure in the circuit and there will be a dip. Whenever you see a dip in the pressure graph, whenever you see a dip in the pressure graph, pressure time scaler, there means the patient is in need of more flow, patient is in need of more volume. So how can you correct this? Provide more flow. Instead of 45 liter per minute, give 60 liter, 70 liter, 80 liter, and then see how this is happening. Increase the tidal volume from 450 to go to 480, 490, 500. Whether see whether it is it is correcting the hunger of the patient. So these are the common asynchrony. Two three things more which we have covered is if your peak inspiratory pressure is going very high. If peak inspiratory pressure is going high, you need to see whether it is due to resistance or whether due to is it compliance of the problem. Get an inspiratory pause. See if the airway resistance is increasing, that means it could be tube biting, secretions in the tube, mucus plug in the tube, or there can be bronchoconstriction, or your HMF filter is getting blocked somewhere, or your VT tube is too narrow. So this is, if peak pressure is high, you put an inspiratory pause. Then if your plateau pressure is high, that means patient is developing either pleural effusion or atelectasis or pulmonary edema or collapse of the lung, or in pneumothorax or hemothorax, initially plateau pressure will lie and later on total pressure, airway pressure will also lie because pneumothorax will start compressing the lung and then it will start compressing the airway also. So that's the way it will happen. So In volume, if you find a decrease in the volume of the patient, volume is not getting completed, it is going up and it is coming and then a drop, then you need to see whether there is a leak in the circuit. Whether most common is in HMF filter, there is a port for bronchoscopy, it remains open, so there is a leak from the there, so that you can see. A trapping auto peep, you need to look at the flow time scaler. If the expiratory phase is not getting completed, that means your air is trapping, you need to do bronchodilation, increase the expiratory phase by adjusting the expiratory. So these were the troubleshooting which usually common comes in. Uh, so we were scheduled to close it before 12, before 2. We have covered today, what we have covered today is uh, what we have covered today is basics of ventilator, uh, graphs and troubleshooting. If you all want, can we have a 15-minute session on Zoom so that we can discuss any doubts which you people are having? I can post the link in the comment section. What all you say? We have still 17 minutes left to end before 2. If you all want, I can have a Zoom schedule very fast for 10 to 15 minutes, so that if you have any comments or opinions or any suggestions or any doubts, we can discuss live. We can end the live stream here, but we'll post the Zoom link for 15 minutes there. We will continue to answer those questions on the Zoom, if at all. Otherwise, if it's getting too toxic or if it is you people are tired, we can now end the session here. You can post your comments, doubts in the comment section, and then I will try to make shorts or different videos on those comments in that. In the next session, because now I think in live stream is comfortable, uh, we will cover different types of ventilation, like ARDS ventilation, COPD ventilation, है ना? Like that. So I think we'll schedule a next Zoom session later on and live stream later on, and specific topics like ARDS ventilation, COPD ventilation, different alarms on the ventilation, other advanced terminologies, and we'll have some people on the Zoom also at that time so that we can have live interaction. So I think this was a marathon run of 4 hours, and I see more than 100 people are there live who remain connected with us whole the time. We'll try to do one session from live from the ICU itself. And thank you to all of you. I think if you have any comments, else we'll close the session for now. Okay, thank you all. Thank you to all of you for providing good feedback. And I hope this gives me encouragement to continue sessions like this in the future on all the topics of the ICU. Not only this, we can discuss DK, we can discuss stroke, we can discuss blood gases, we can discuss hemodynamics, everything we can discuss in it 1 or 2 session. 1 hour lecture or 90 minutes lecture. 4 hours is a longer time, but we need to have a discussion on ventilator in a stretch so that nobody has missed something, get an idea. So we'll close it, and I'll keep this session posted on the YouTube also. So if somebody has skipped something, you can see there also. Okay, weaning modes of ventilator before ending. So your SIMV mode is there, but we don't use it. Pressure support mode is the weaning mode which we use it most likely. Pressure support mode. Thank you. Thank you. So we'll close it. Thank you all for all the. Thank you all for joining. Keep posting your doubts in the comments. In the comments, we will respond. Thank you. Have a good day. I'm ending the stream, है ना?